All right, good morning, everyone. Being 9 o'clock, if you'll join us in the pledge, Senator General is going to lead us.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Well, good morning. It's always good to see a packed house in ED&A. Hope you all found the roads to be safe in your travels here. A couple quick things before we get going. I want to welcome our new intern, Edie. She is starting today, and should be a fun and exciting experience for you. Especially since we have a page and a half of sign-ins on the first bill. That'll be good. As always, Kevin, we want to thank you for the work you do for us, too. With that, we have our prime sponsor here for our first bill, Senate Bill 440. So we will open the hearing and recognize Senator Ward to introduce the bill. Good morning.
Good morning.
Morning.
Morning, Mr. Chair and members of the committee. For the record, I'm Senator Ruth Ward from District 8, which goes from Dunbarton down to the Connecticut River. I'm here this morning to testify on behalf of the optometrists on the Senate Bill 440. The doctors of optometry in New Hampshire currently practice only what the statute allows. This puts the legislator in the position of making clinical decisions. I believe the time has come for doctors of optometry to be treated in the statute like other doctorate-level health care providers. SB 440 does just that. In a nutshell, it authorizes the Board of Optometry to regulate the practice of optometry by determining the qualifications of certain procedures and provides a list of procedures excluded from the practice of optometry. You have all received an amendment that adds to that list a procedure inadvertently left off the initial list of excluded procedures in the bill as introduced. Based upon curricula from schools of optometry, these doctors attend, and based upon many years of performing advanced procedures in other states, the experience and evidence clearly demonstrate doctors of optometry are fully capable of performing advanced procedures. SB 440 will eliminate the need for new legislation each time there is a charge in curriculum. This is important to the citizens of our state, as our aging population and eye health issues are outpacing providers. People following me will present that data. SB 440 makes other updates to the optometry statute that will be described in subsequent testimony. The map of authorized procedures across the country makes no sense. Doctors of optometry do not lose or gain capability when they cross state lines. It's time the regulatory board of this profession, like other healthcare professions, is allowed to make these decisions based upon education and training, not politics. There are quite a few people here presenting testimony in favor of SB 440 that can speak in much more detail on or answer questions much better than I can, since I'm not an optometrist or an ophthalmologist.
Thank you, Senator. Any questions? All right, seeing none, we appreciate you bringing the bill in.
Thank you very much.
All right, so I am counting 14 people that would like to speak on this bill, which is great that we have that much input that the panel board can receive. I'm going to ask everybody to please try and keep your comments to 3 minutes or less so that we can get through this at a reasonable hour, because we do have other bills after this that we need to hear, and we have kind of a hard stop at noon. So I'm going to just kind of go through and rotate some for, some against, so that it's not going to be weighted in any particular direction. And I think we will start with the Board of Optometry seems like a good place. So Dr. Christine Donahue. Good morning and welcome to ED Day, and I'll remind everybody, please turn the mic on before you start testifying. Thank you.
Good morning. Thank you. Members of the Senate, thank you for the opportunity to speak to you today. I'm Christine Cabin Donahue, Doctor of Optometry. I'm a second-generation native optometrist to New Hampshire, born and raised in Bedford. I am board certified through the National Board of Examiners in Optometry. I'm a member of the Joint Credentialing Committee and, as you said, the president of the New Hampshire Board of Optometry. I am here today on behalf of the board to show our support for Senate Bill 440 and highlight a few sections of the bill for you. Much of this bill is related to the role of the Board of Optometry. New Hampshire has a long-established board whose current members combined have over 90 years of experience practicing as doctors of optometry. The mission of the board is to ensure that qualified optometrists are permitted to provide services to the citizens of New Hampshire. The board determines the qualifications necessary to obtain a license, how applicants should be examined, issues licenses after examination, determines and upholds the ethical and professional standards for licensees, determines the prescriptive authority for medications, including controlled substances and medical devices, monitors the competence of licensees through continuing ed, and determines what constitutes professional misconduct within the profession. The board provides oversight of its licensees and has the authority to take disciplinary action when necessary to ensure that the highest standards are maintained. We have an ethical obligation to uphold that standard. Senate Bill 440 cements that role in statute and allows the board to determine what constitutes the practice of optometry in New Hampshire and the credentialing requirements necessary. Being seasoned already in the regulation of the profession, we will perform the functions this bill authorizes with the utmost care, approving procedures with appropriate training and public safety for most of our decisions. Optometrists in this country hold a doctoral level degree. We are certified at the national level. We are independently licensed and practice independently without any requirement for supervision by any other profession. Despite this, in New Hampshire, we are the only doctoral level profession that is not self-regulated with board autonomy. All comparable professions, such as dentistry, podiatry, and physical therapy, are. We are asking to be commensurate with the other doctoral level healthcare professionals in this state. In a climate where education and training are constantly evolving, these changes should be regulated by the regulatory board of that profession, just as the other regulatory boards in New Hampshire do. The delivery of eye care in New Hampshire should not need to burden the legislature with decisions and adjustments every few years to keep up or catch up to optometric technology, education, and certification. This bill will also officially dissolve the Joint Credentialing Committee, and the board deserves this. Started over 20 years ago, the Joint Committee granted optometrist glaucoma certification. In my time on the committee, every single applicant was unanimously granted certification without any question. Moreover, the committee has not met since 2020, as there have been no applications brought before it. Some committee members need to travel over an hour to Concord one way for a 7-minute meeting and then just turn around and have to drive that hour home. This bill also addresses an unintended consequence of change in federal classification of controlled substances. Decades ago in New Hampshire, doctors of optometry were authorized to prescribe hydrocodone-containing pharmaceuticals, and did so without issue to the benefit of our patients suffering in pain from painful ocular issues. A few years ago, the federal DEA changed these medications to a schedule controlled drug, which state statute prevents us from prescribing. We do support the cleanup of our statute to maintain the restriction on Schedule II drugs with an exception of a 72-hour supply of hydrocodone-containing pharmaceuticals with no refills. The last section of Senate Bill 440 I would like to discuss is the continuing education requirements. The board also supports amending these requirements. This change only removes the independent study requirements, which are difficult to verify, leaving the 20 hours of live classes per year intact. 20 hours is in alignment with other states and other medical professionals in New Hampshire, including dentistry and podiatry. The national average of live hours of optometrists is 20 per year, with the range from 12 to 25. At 50 hours, New Hampshire is definitely an outlier. In closing, I believe that New Hampshire is a hidden gem in this country. I would love to see our seasoned doctors stay in this state. I would love the best and brightest young doctors of optometry to come to New Hampshire. But to guarantee that, we need to update our laws and ensure a system going forward so that they stay current, meaningful, and relevant. Thank you.
Thank you very much. I'm going to start off with one question. Do you have a copy of the bill in front of you?
I do.
All right, so and this is in several places, and if you're not the right person to answer it, perhaps somebody after you.
Sure.
Starting right off on line 10, we're changing the Board of Registration in Optometry to just the Board of Optometry.
Yes.
What exactly does that change?
I think it's just semantics that it's written in the bill as Board of Registration Optometry, but now the OPLC, we're just the Board of Optometry. Yeah.
That's kind of what I thought, but I
Yes.
just wanted to make sure there wasn't something there that I wasn't seeing.
Yes, it's
All right.
been quite a while since the bill's been, since the statute's been
Yeah.
updated. Yeah.
All right. I'll open it up to the committee for questions. Senator Perkins Cuoco.
Yes, thank you, Chair. And I apologize because perhaps the sponsor mentioned this and I missed it, but I'd be interested if you or anyone else here can address, we obviously have an amendment here in front of us. Are you familiar with what the changes are?
I don't have that amendment right in front of me, but.
Okay.
Oh, yes. When the bill was drafted, inadvertently, we left off the exclusion of LASIK. A lot of people might have heard of LASIK.
Yeah.
It's a technique where the front curvature of the eye is changed to eliminate the need for glasses. That's currently not something that we are looking to do at this point. So we wanted to make sure we added that to the exclusion list.
Okay, thank you.
You're welcome.
Further questions from the committee? Seeing none.
Thank you.
All right, Ava Hawks. No, sure. Welcome back to the Senate.
Thank you.
You have a different capacity now than you
So
used to.
different being on this side of it all, but I'm happy to see you all. Good
Good
morning.
to see you again.
All right. I will keep it as brief as I can as we have plenty of experts behind us. But good morning, Mr. Chair, members of the committee. For the record, my name is Ava Hawks. I am the Director of Advocacy for the New Hampshire Medical Society. The Medical Society strongly opposes Senate Bill 440. Senate Bill 440 would allow optometrists who are not medical doctors or trained surgeons to perform eye surgeries using scalpels, lasers, and other surgical modalities, setting a dangerous precedent for patient safety in New Hampshire. As you will hear from expert physicians in the field later today, ophthalmologists complete 4 years of medical school and 4 years of a hospital surgical training program before they can independently see, treat, and when medically necessary, perform surgery on a patient. That is not the case for optometrists. While New Hampshire Medical Society's membership is acutely aware of the impact that the current healthcare workforce shortage has on access to care in New Hampshire, our state's physicians, which includes ophthalmologists, are not willing to risk patient safety and health outcomes as a result of legislation such as Senate Bill 440 by dangerously expanding the scope of practice of certain healthcare providers in our state in the name of increased access to care. For these reasons, the Medical Society asks the Senate ED&A Committee to recommend inexpedient to legislate on Senate Bill 440, showing that we continue to prioritize, not undervalue, the medical education, clinical training, and high standards of our state's physicians that have led to our high-quality healthcare system. I am happy to take questions, but again, I'm confident there are a plethora of experts, ophthalmologists, optometrists behind me that could answer those questions more in depth. And I will say, Senator Perkins Cuoco, I did hear there was an amendment, and if my testimony speaks to the as introduced version, I will make note of that because I have not seen the amendment.
So I'll start off with one question. So in your testimony, and I'll try to get these terms right, optometrists and ophthalmologists,
Yeah.
I'm still learning the difference between the two. But,
Yeah.
So do other states allow optometrists to do these type of surgeries when, you're talking about using scalpels, laser, and other surgical modalities? Do other states allow optometrists to do those kind of procedures? Do you know?
So I'm only really familiar with what we allow in New Hampshire, so I can't speak to other states, but I'm certain folks behind us could speak to the differences between what we currently allow in New Hampshire and what this bill is proposing.
Excellent. I'll throw that question out, and anybody that
Thank
wants
you.
to answer it,
Yeah,
we'll look
I'm
forward
sure
to it.
plenty of people will answer that.
Further questions? Senator Perkins Cuoco.
Yes, thank you, Chair. Yeah, I think
similarly, I'm not going to imply that you are the expert on these procedures either.
Thank you. Thank you very much.
We obviously have a lot to digest as committee members, and so, I think we're going to try to do that as best we can. But the meat of this bill, obviously seems to center around what is and is not the practice of optometry. And one of the changes I note is that we're removing other than surgery. So, we have this list here of shall not mean the following ophthalmic surgery procedures, except for preoperative and postoperative care. We have this list. Above that is sort of, I think, what the optometrists are asking to practice. So I guess one of the things I'd like to drill down on that I'm not feeling like a lot of people are talking about is what are the procedures that today optometrists cannot do exactly that they are asking to do under this bill. And just the way it's drafted, I'm not sure that is apparent to us if we read it.
I agree. I think the way that the bill was drafted as introduced, the way it's listed as exceptions, I think makes it unclear for the average reader, for a legislator, for even folks who, optometrists who are familiar with this area of statute. The way that it's written, it's not as clear as I would have liked it to be, and I think that lead into confusion for folks. So I don't want to tap specific people, but I'm sure Dr. Kim McCarty, who is the president of the Eye Physicians and Surgeons, would be more than equipped to kind of speak to that.
Okay, and then I'm going to ask you a question that, again, you or others can answer, but I'm interested in the same thing the chairman mentioned, which is just, what is the practice in other states? What is the safety rating? What are proxies for us to look at how this is working outside of New Hampshire or not working? So, again, I don't know if you can speak to that, but it's just something I'd like for people to address.
Yeah, thank you for the question. So following today's hearing, depending on the level of detail that folks get into about how other states mirror what's being proposed in Senate Bill 440, I am happy to follow up with some other statistics and data on that for us, for the committee.
Thank you very much.
You're very welcome.
Further questions from the committee? Seeing none,
Thank you.
I think we will call Dr. Kim McCarty and see if she can answer these questions for us.
Great.
Good morning and welcome to EDNA.
Good morning. Thank you for the opportunity. I can answer some of your questions. We've kind of had an order going, so I might address some different areas here. First, my name is Kim McCarty. I'm a physician practicing at New Hampshire Eye Associates in Manchester. I've been there for the past 14 years. Prior to that, I attended 4 years of medical school at the University of Buffalo, followed by a 1-year combined internship in medicine and surgery at the University of Pennsylvania. And then I did do a 3-year residency in ophthalmology at the University of Illinois in Chicago. And I'm currently the president of the New Hampshire Society of Eye Physicians and Surgeons. And my colleagues, we have it planned. I have a few that are going to get into the exact procedures that are proposed and the details and risks. So I know one of the concerns here amongst probably the legislatures in particular is lack of access to care in the state of New Hampshire. And this has probably been cited as the primary reason to expand the scope of the optometrist. Can we hand out the packet? We have a packet to hand out here with some information. One of the items in the packet is a map of the state of New Hampshire, and it gives drive times to an ophthalmologist. And as you can see on the map, 90% of the New Hampshire population does live within a 30-minute drive to an ophthalmologist, and the remaining live within a 60-minute drive, with the exception of the very far reaches of the North Country. Some of the other concerns that might be voiced is, are optometrists actively leaving the state of New Hampshire to go to places where they can perform lasers and eyelid surgery? So there is another graph in there, and of the 239 optometrists that did file Medicare Part B claims from 2013 to 2020, 0 went and filed a Part B claim elsewhere for laser surgery the following year. So that means if they did relocate, they did so for other reasons, not because they were looking to expand their scope of practice. And in fact, not being allowed to perform some of these procedures is not keeping new young optometrists from coming to New Hampshire. There is another handout in your packet, And from 2013 to 2023, New Hampshire has added 73 new young optometrists, and that's a growth rate of 45.8%. Meanwhile, the overall population growth rate for our state has been 5.6%. So that means that the young optometrists are coming to our state to take advantage of what we have to offer, and that goes well beyond their licensing laws. We want to continue to attract quality providers for the right reasons, not because Live Free or Die also includes medical care. The other side to this debate is that there's not enough ophthalmologists. And we have a pretty big contingency of people who are in private practice in our state that are standing in this room with us this morning. And all of us have retired some of our senior partners in the past few years. Conversely, we've all actually been able to recruit new young ophthalmologists, some who are standing in this room with us right now. And I've been truly impressed by the number that we've actually been able to attract in the last few years. And our colleagues at Dartmouth have shared with me the exciting news that they actually have 3 new ophthalmologists joining their department this year, including 2 new retina specialists. So we, the ophthalmologists of New Hampshire, we're here. We are available. We have appointments. We accept Medicare and Medicaid. We're on call after hours for our patients, for local hospitals, and we're committed to providing expert care to the citizens of the state. My colleagues will get into more of the differences between our education, but if you needed a laser or eyelid surgery, would you wait a week longer or drive an extra 15 minutes to an ophthalmologist with 4+ years of training? Or would you have an optometrist who took a 32-hour weekend course? You may understand the difference by the end of this morning, but your constituents may not. Thank you for your time and consideration.
Thank you for your testimony. I am trying not to make a bad eye pun here, but I can see clearly that there's a lot of dark blue on the map. I guess I think you may have touched on this a little in your testimony, but I guess, my thought was when I looked at this, there's a lot of coverage, certainly for the southern 2/3 of the state with the ophthalmologists. Are there, is the workload so heavy that they're able to take on new clients, or are you seeing that there are longer wait times? I know you sort of touched on this. I guess I'd like a little bit more in depth on that about the average waiting time to get into an ophthalmologist.
So if you just called an office and said, I just want an eye checkup, they'd probably say, okay, there's an appointment in 6 months. Mm-hmm. My office in particular, and a lot of the other private practices, if you call and you say, I have a problem, I need a laser from after my cataract surgery, we have appointments available for that. My colleague, Dr. Goldblatt, who you'll hear from, he had 5 openings for lasers the other day. So a lot of the times you just have to call and be a little bit more specific. But we are generally very accommodating. Particularly with eyelid procedures, our private practice oculoplastic surgeons have a lot of availability to handle that.
So typically, what would you say the waiting time would be? A week or less for an appointment?
Probably.
Okay.
If you called my office for my partner who's an oculoplastic surgeon, she'd probably have you in within a week.
Yeah, I realize that's just an estimate. But
Yes.
Okay, thank you. Further questions? Excuse me, Senator Altshuler.
Good morning. Thank you, Mr. Chair, and thank you, Ms. McCarty, for being here. And wow, there's some reading material here. Thanks. Appreciate that. In the practice that you have right now, do you have optometrists working in your practice?
Yes, we do.
And are they, what is their scope of practice within your practice?
So they're an important part of our team. A lot of them provide just complete eye care to people who just need contacts and eyeglasses. They screen for diseases like glaucoma, and some of them do treat glaucoma as well. Mm-hmm. And they do contribute to seeing emergencies with us. And our optometric colleagues are a very important part of our team. But they do not perform procedures.
Okay. Thank you. May I follow up?
Oh, sure.
Yeah. So in looking at both the original bill and the amendment, I don't know if you've had a chance to look at the amendment.
Yep.
There is a rather extensive list of shall nots. And you mentioned in your testimony that your hypothetical was, would you rather wait to go see someone who can use laser versus someone who, and that's,
So-
like, that's actually not what we're talking about. So I'm wondering, could you clarify what you were talking
So
about? Because
this-
laser is off the table.
So that's one particular laser,
Yeah.
LASIK. There are many different lasers that we use in the field of ophthalmology, and there are a few very specific laser procedures that are not on the exclusion list that they are specifically looking to be able to perform.
May I follow up?
One more,
Could you, yeah, so I would like if you could be specific, because when I'm looking at both, I don't think there's much, I don't see the differentiation, but if you have the original bill in front of you, or the
So-
amendment, there is, actually, I'm looking at 1, 2, 3, like 4 specific laser
Right.
surgeries that are off the table. So it would
Correct.
seem to me that if we had to list them specifically, those would be particular procedures that an optometrist in your practice who identified some problems would be then referring them across the hall to you. Is that right? Like, is that how your practice works with optometrists, ophthalmologists?
Yeah.
In collaboration?
Yep. Yes. If one of my optometrists has been treating someone for glaucoma who needs a laser for that, they would then refer the patient to me. But the way that this bill is written, this is not everything that we do. And there are 3 very specific laser procedures that the optometrists are looking to add into their scope of practice. A YAG laser, and I have my colleagues prepared. I was supposed to go last. I have my colleagues prepared to explain these in depth to you, but they're looking for a YAG laser capsulotomy, a glaucoma laser called selective laser trabeculoplasty, and another sort of glaucoma laser called a peripheral iridotomy. And I do have a glaucoma specialist prepared to actually go into depth as to what those are. So the nature of the language in this bill very, very carefully does not have certain procedures on the exclusion list, and that is our primary concern as ophthalmologists.
Thank you for your testimony. Further questions from the committee?
Last question?
One more?
Yeah, thank you. I don't know how long you have been practicing in the state, so I won't assume any institutional knowledge of you know, the changes in OPLC and all of the boards, and this is where we have all our fun, isn't it?
We are the fun board.
We are. Yeah. Welcome to Funtown. So, and as the Minister of Fun, I would like to bring your attention to this struggle over what seems almost territory of practice is one that New Hampshire, we've done this before. We've done it in many other venues.
Yes.
And so you'll forgive me if when the people who are coming after you, and if you want to address this too, that this is a familiar song that that many collaborating fields of medicine sing when one wants to be able to increase their scope of care. And so we kind of did this back in the early 2000s with glaucoma, and the world was going to fall apart if the optometrists treated glaucoma. And turns out we actually were able to increase the number of people treated for glaucoma. So what I'm driving at here, is this a territorial squabble over practice, or are there actually significant differences in trainings and in education because it seems like this is a incredibly thoughtful exclusion list. And with regards to your previous testimony, and I love the map, But in my area, that is not how things roll out at all.
Sure.
While you may be able to drive to an ophthalmologist, if you are not savvy in what you need to ask for, and you are an elderly person, and I live with one, and don't know that I need to ask for the laser, but I'm having glaucoma issues, yeah, you get put on a 6-month waiting list. And I'll tell you, at 80 years old, 6 months is a very, very, very long time. So, you know, it's very difficult to rise that escalation level. So if there were people that could do this, why would we not want to open that door a little bit?
I think our chief concern is actually patient safety. One of our other speakers today is a resident, an ophthalmology resident from Dartmouth, and he's going to get into some of the big differences in our education and training. And we will specifically address the procedures that they're looking to obtain, as well as the potential complications.
Excellent. Further questions? Seeing none, thank you today.
Thank you.
For coming in today, Amy. Dr. Allison Laranger. I'll just remind everybody, and so far everybody's done it, but just to state your name and if you're representing someone in specific, to just so that Kevin can get that in the record. Thank you.
Okay.
Welcome.
Is the mic on? Yep. Okay. Well, Mr. Chairman, members of the committee, thank you for the opportunity to speak to you today. I am Dr. Allison Laranger, born and raised in Bedford, New Hampshire. I have a Bachelor of Science in Biology from the University of New Hampshire and a doctorate in optometry from the New England College of Optometry in Boston. I am double board certified through the National Board of Examiners in Optometry and the American Board of Optometry. I live in Goffstown and practice in Manchester at New Hampshire Eye. My optometric colleagues and I are here today to ask for your support of Senate Bill 440, a bill to modernize the regulation and practice of optometry in New Hampshire. I will answer some of your questions in my testimony that have come up already, but I want to be very clear that nothing in this bill that is anything that's not covered in the exclusions cannot be allowed if it's not within our education and training in optometry schools. So there's no procedure, no surgery that is, we're going to go rogue and do things that we're not trained to do. That is not what we're in this for. We are also in this for safety and for patient care, quality patient care. So like other doctoral level healthcare providers in New Hampshire, doctors of optometry practice independently and have never been under any governance, supervision, or restriction by any other profession, including ophthalmology. As doctors, we independently prescribe topical and oral medications, order labs and imaging, perform minor surgical procedures. So yes, there are some surgical procedures we are already doing. Diagnose and treat ocular diseases and emergencies, take after hours call, and dictate the treatment and management of our patients. While there is overlap between the professions of optometry and ophthalmology, we remain independent of each other. Yet, unlike all other independent doctoral level healthcare professions in the state, only optometry is required to pass legislation and to overcome opposition from a separate independent profession in order to be permitted to use our education and training. The New Hampshire Board of Optometry is the appropriate board for regulating the profession of optometry, just as in the case with all other professions. Senate Bill 440 seeks to move that regulation to the board where it belongs, while still maintaining parameters and limitations within statute. The current New Hampshire optometric statute is one that has resulted from numerous legislative actions over time, each action being necessary to bring the statute up to date with healthcare advances. As such, the statute is complex and convoluted. By establishing a broad list of statutory exclusions, which are outside of optometric training, and by granting the Board of Optometry the authority to regulate the profession within those exclusions, Senate Bill 440 aligns the profession of optometry with similar doctorate-level independent healthcare professions. As you will hear from one of my colleagues, the board has the ability and the obligation to ensure that New Hampshire optometrists practice only within their education and training. Senate Bill 440 modernizes the regulation of optometry and the practice of optometry. This is not progressive or novel legislation. Optometrists have been performing the procedures permitted in Senate Bill 440 in dozens of states and for more than 40 years with safe and effective outcomes. 11 states allow optometric laser procedures, 19 allow removal of eyelid lesions, and 41 have injectable authority. The opposition claims that this bill will allow optometrists to do hundreds of surgical procedures, but the truth is, Senate Bill 440 allows optometrists to perform 42 surgical procedures, 12 of which are already permitted in New Hampshire statutes, such as foreign body removal, eyelash epilation, inserting plugs into the tear ducts, etc. All procedures permitted by Senate Bill 440 are minor in-office surgical procedures that have been taught in optometry school for decades and are not advanced eye surgeries, as the opposition claims. The opposition to Senate Bill 440 relies on baseless claims of risk to patient safety. The same argument has been made repeatedly for decades to maintain the medical monopoly, and none of these claims have come true. This fear-mongering only serves to allow them to control markets and prevent competition. Hundreds of thousands of these procedures have been performed by optometrists in other states since the 1980s without any increased incidence of complications when compared to ophthalmology, demonstrating 40-plus years of safety. This rhetoric from the opposition aims to continue preventing qualified eye doctors from providing care to New Hampshire citizens in a climate of provider shortages and access issues. The opposition will tell you we do not have the same education as them, and we agree. However, we do not want to be ophthalmologists. We want to be optometrists to the full extent of our education and training, which includes the procedures outlined in Senate Bill 440. Medical school is not the only place that in-office procedures can be taught. Optometrists, dentists, podiatrists, nurse practitioners, etc., learn our specialties outside of medical school. In fact, nurse practitioners without a doctorate degree and with little ophthalmic education are allowed to perform some of these procedures in New Hampshire, yet doctors of optometry cannot. I recently saw a patient who was 104 years old whose vision was decreased to a haze that commonly develops behind the lens implant after cataract surgery. If I were still practicing in Colorado, I could have treated her that day within minutes. However, simply because I crossed a state border and returned home to New Hampshire, I am somehow perceived as being less educated and less qualified. This patient had to return on a different day with her daughter, who needed to take more time out of work to see a different provider that she's not familiar with, but happens to be in the very same office, increasing the burden on the patient, the family, the other provider, and the healthcare system. We all have a common purpose of providing safe eye care to the citizens of New Hampshire, and for the right reasons with outcomes and access in mind. Safe, quality eye care, including in-office procedures, is not exclusive to ophthalmology. It is time to work together and allow the optimal use of all healthcare providers to address the needs of our patients. Thank you for your time.
Thank you for your testimony. Questions from the committee? Senator Altshuler.
Thank you, Mr. Chair, and thank you for your testimony. I think I heard you just say in your testimony that you practiced in Colorado, and then came here in New Hampshire. Or I'm sorry, what was the? And there is a procedure you could have done there that you can't do here. Could you just explain what
Sure.
that is?
Sure.
And what the barrier is here? Was it because we have talked a lot about wanting to make sure that when people come here to New Hampshire and get certified by their appropriate board, and when we're talking about compacts and acknowledging other licenses, that the level of education is at the New Hampshire's minimum, not another state that may not require as much. So could you speak to that?
Sure. So optometrists are certified on a national level. So there are not varying levels of our education and training. We all graduate with a doctorate in optometry. And so when I was in Colorado, they have since passed these laws since I was there. But if I were still there, that patient, I could have used a laser and lasered off that film within a few minutes. And she could have gone home, and that would have been that. Did that answer your question?
follow up?
Sure.
So using the laser to remove the film on the cataract, you could do in Colorado, but you can't do in New Hampshire.
Right.
But the training is nationalized, so you've been taught to do that. Obviously, you've been taught to do that, but it's not specific to Colorado that like we teach people in Colorado to do this, whereas people in New Hampshire don't know how to do this.
No, optometry
Okay,
students.
so it is national.
It is national. Optometry students in the current curriculum that has been this way for years are learning lasers or learning minor surgical procedures and injections, and that is standard in curriculum. So for doctors who graduate and did not have this training, let's say a decade ago, there are continuing education courses and in-person labs that train providers on these types of procedures and lasers, and that is how all doctors learn new things. Nobody goes back to medical school. Nobody goes back to optometry school. But when medicine advances, this is how we learn and we build on our foundation of education.
Thank you. Further questions? Seeing none? Thank you. We will go to Warren Goldblatt. I apologize to anyone if I screw up the names. I'll do my best.
Good morning.
Good morning.
My
Welcome.
name is Warren Goldblatt, and I do love eye puns. The cornea, the better. You started it, Senator.
It's going to be a long morning. I know I did. I'm sorry.
I'm here today to speak in strong opposition to Senate Bill 440, which seeks to remove many of the patient protections in this state by expanding the scope of practice of optometrists in New Hampshire. I'm an ophthalmologist in group practice in the Seacoast. I have offices in Portsmouth, Exeter, Somersworth, and even Kittery, Maine. And I've worked side by side with optometrists for over 28 years, both in my practice and outside the practice, and recognize that we are a team, and our distinctive skill sets complement each other. And while there is some overlap, surgery is not one of them. Most people don't understand the difference between an ophthalmologist and an optometrist. Ophthalmologists, 4 years of medical school before undergoing extensive residency training in caring for the eye in a medical and surgical fashion, from an optometrist who goes to optometry school after college and can then practice. And speaking to the last testimony, there's only about 10 or 12 states in the country that allow some of these procedures, and only a couple of states have optometry schools in them. I will tell you that in my office, we have externs these are fourth-year optometry students coming from the New England College of Optometry in Massachusetts, out in Boston, and the Southern College of Optometry in Memphis. And they only get training on model eyes, only on a model eye, not on a human being, unless they choose to do an externship in one of the states that do provide them. So the training is not the same everywhere in the country. Whereas in ophthalmology, every ophthalmologist has to have a minimum number of cases per procedure. That's just the way it is. After getting my undergraduate degree at Cornell, thank you. You went to Cornell, Senator? Did I hear that? Yeah. I went to medical school for 4 years, which included not only basic science, but over 2 years of supervised clinical face-to-face training with patients, both medically and surgically. I then did a 1-year internal medicine internship, working 55 to 80 hours a week in direct supervised patient care. Hell, I spent 3 months in the ICU taking care of critically ill patients. So we are all trained physicians. And then I did a 4-year residency in ophthalmology, again, with direct patient contact, taking care of the sickest segment of our population, the people with the most complicated things, because these are the patients that residency programs attract. And all of this was done under the direct supervision of board-certified ophthalmologists. And my colleagues have similar training consisting of years, not days, not weeks, not weekends. And these years consisted of examining, diagnosing, and treating with medication and/or surgery, and most importantly, caring for the complications of an actual eye and not a model eye, all hours of the day and night. And we do it over and over and over again until we are experts. We all know when to point a laser at someone's eye or put a scalpel to someone's skin, and more importantly, when not to. We've all easily put in our 10,000 hours to become experts. In fact, it's about 17,000 hours for a standard 3-year residency. Some of us do a 4-year residency like me. Some of us do fellowships where 1 to 2 years after that. Atul Gawande, a famous thyroid surgeon, author, has said the following: the difference between triumph and defeat, you'll find, isn't about the willingness to take risk. It's about the mastery of rescue. Think about that, the mastery of rescue. The optometrists are willing to take the risks, but they just don't have enough expertise. As ophthalmic surgeons, we live this every day. I don't fault the optometrists for not thinking this way. They're not trained as surgeons. They may think that lasers or lid surgeries are easy to perform, but they can all have vision-threatening consequences. Therefore, expanding their scope in the manner proposed by this bill will endanger the eyes and vision of our citizens. You heard it's a question of access. It's a question of patient safety and quality of care. Lowering the standard of care by allowing those with far lesser training experience to perform surgery and procedures is not improving access. And the public does not want substandard care proposed under the guise of need. Again, the lay public does not understand the difference in training and experience. This is a medical issue, and unfortunately, it's fallen upon you to make this very serious decision. I also have concerns about the requested 60% reduction in continuing medical education credits and removal of all formal education. MDs are currently required to do the exact same thing. It's 100 continuing medical education hours over a 2-year license schedule. And for us, for opioids, it's 3 hours of opioid prescribing. And this bill also proposes the use of opiates by the optometrists. I have personally not had to prescribe an opiate for over 10 years. And if I ever have to do it again, it'll be one time too many. Have any of you seen the New Hampshire checklist for prescribing opioids? It's in your packet. It's very complex, time-intensive, and New Hampshire rightly did this to combat the very serious opioid problem that's currently worse than ever. And there's many alternatives. In fact, alternating Tylenol with Motrin can give you opioid level of pain control. Again, this is a medical issue, and you've all been tasked to make this very critical decision. The very famous oil well firefighter, Red Adair, I don't know if you've heard of him, but he is said to have made the following statement: if you think it's expensive to have an expert do the job, wait until you hire an amateur. Please, don't make New Hampshire citizens pay this price. Thank you.
Thank you. Questions? Senator Perkins-Coie.
Yes. Thank you for being here. Thanks everyone for being here. I know this is a really detailed conversation that's important to a lot of you. One thing you mentioned was sort of direct supervision, and so again, I'm going to kind of pose a question that you can respond to, and I'd welcome anyone else's input on. But during training, you and I discussed that ophthalmologists do sort of a traditional residency. I'd like you to kind of detail that a little bit, and I guess I'd also welcome the optometrist to comment on, sort of under what supervision are you gaining experience in the procedures that we're proposing to include today, and are they under direct supervision of sort of another licensed person? Sort of how does that training work in the optometry field? I'm trying to understand both. So,
well, again, there's only a couple
My
of
question
states that
clear?
allow lasers done on actual human beings in
Yep.
optometry school. You have
Yep.
to go elsewhere, otherwise it's a standard eye. You talk about training. So my wife is an internist in Dover. So I met her during my internship. I did the exact same internship that she did. And if you have an internist as your doctor, my first year was the exact same as their first year. Many of us do transitional years where it's part medicine, part surgery. Some of us do a strict surgical internship where you're basically just like your surgeon, exactly the same, so no different. Again, hours and hours. A 60-hour week was a short week for that first year, and then we do our ophthalmology residency training program. Yes, we have board-certified ophthalmologists teaching us when we do our laser procedures on people. There's someone there with us. And again, there was a critical number or a certain number that every single ophthalmology resident needs to do in order to graduate from residency, never mind being board certified. Did that answer your question? Or was there more? I mean, again, let's talk about pharmacology. Yes, I'm sure they get training in pharmacology in optometry school, just like I did in medical school. But then I'm prescribing those medicines. I'm prescribing those medicines under the auspices of someone ahead of me, above me, in 3rd and 4th year medical school. as well as when I'm an intern, I'm actually the one prescribing medicine. So I know, what medicines are blood thinners. I recognize these medicines. I see them all the time. We're trained to think differently. We're trained to think of the entire body and not just the eye.
Further questions? Seeing, Senator Altshuler.
Thank you, Mr. Chair. Thank you so much for your very detailed testimony. Are you giving that to Kevin on your, so we're going to have a copy of that?
I certainly can if you'd like it.
Yeah, that would be great. Yeah, thank you.
Most of it's in there.
Yeah, we review this before we,
Okay.
go make decisions. So it'd be nice to have that to refer to. I appreciate it. So I have two questions, not necessarily related. It's my understanding, because you brought up the reluctance to use hydrocodone or oxycodone, any kind of opioids, and with those drugs should be, we have all agreed that those should be administered with great care. And we've made a lot of changes in New Hampshire to how they're prescribed. It's been a long road, and we've had a lot of people that were hurt along the way. But I think I understood that optometrists had the ability to prescribe this until the schedule changed. And then it was the schedule change that buffered them out. And so this bill folds them back into a space where they had already been. So I don't know that they didn't get the same kind of training you did. And I know that we require any prescribers to now do professional development trainings. So would you speak to that a little bit more?
I have no knowledge if that's the way it was. But I'm
Okay.
saying, as an ophthalmologist who sees roughly 40 people a day, I have not had to prescribe. When I say 10 years, it's probably been more like 15 years. It's rarely necessary in a general ophthalmology practice, and I can't imagine it's necessary in an optometry practice either.
Okay, thank you.
There's other ways of treating it.
One last question. Thank you,
A follow-up.
Mr. Chair. It's been brought to my attention by the Department of Veterans Affairs that the Department of Veterans Affairs allows optometrists in all 50 states to practice at the top of their field, regardless of what the limitations may be outside within the civilian population. So if an optometrist in New Hampshire is working for the Department of Veterans Affairs and providing a level of care, but then were to leave and then move into a collaborative practice with you, for instance, then it's my understanding that the level of care that they once delivered is dialed back. So-
Senator, I think that's inaccurate, and we have someone from the VA speaking today to
Okay,
that
great.
effect.
Thank you. I appreciate that. I would love to hear some clarification on that. Thank you.
All right, thank you for your testimony.
Thank you.
We will go to Dr. Angel Sawyer. Good morning. Turn your mic on, please. Thank you.
Thank you. Good morning, Senators. It's an honor to speak to you this morning. Before I get into any of my prepared testimony, I do want to kind of hit on a few things that have been said here. First, I want to make it clear that we are not amateurs, that the procedures that we're looking for here are things that are within our training and education and have been for decades. The list of exclusions that you're looking at, there are 262 surgical ophthalmic codes. 42 is how many of those would be permitted. There is a very large number of surgical ophthalmic codes that are still covered under that exclusionary list. And of those 42, 12 of them are what we are already doing. In regards to opioid prescribing, yes, as Senator Altshuler clarified, this is something that we have had the training to be able to do, that we've had the privilege to do before. We already have DEA licenses. We already do get opioid CEE requirements every year in order to maintain our DEA license. The bill put before us limits a 72-hour prescription at most with 0 refills. We do not want to use opioids when we do not need to, and I agree that there will probably continue to be many optometrists who never prescribe it. But that is a authority that we had, and as optometry moves forward and we continue to stay current with our education and training, there may become times when we need that, particularly in light of current access issues. So I would like to get into my testimony because that is largely what I'd like to speak to you about. Again, I apologize, my name is Dr. Angelique Sawyer. I am an optometrist and a practice owner in the rural northern parts of our great state, having office locations in North Conway and Berlin, New Hampshire, where I've spent the last 10 out of my 15 years practicing. I'm here to ask for your support for Senate Bill 440 because it's what my patients, your constituents, and the citizens of New Hampshire deserve in order to better meet their eye care needs. Living and practicing in the most rural areas of our state as I do, and as none of the providers behind me do, I can tell you most critically why Senate Bill 440 is needed is due to a lack of access to care. A 2022 article from Ophthalmology indicates that the number of ophthalmologists in the United States have stayed stable since 1990. 50% of those ophthalmologists are older than 50 years old and closer to retirement than training. This is from their article. Meanwhile, the number of patients over age 65 will increase by 42% by the year 2030 and 83% by the year 2050, again from their article. A study from Ophthalmology in 2023 found that between 2020 and 2035, the supply of ophthalmologists is projected to decrease by 12%, while demand will increase by 24%. This ophthalmology supply-demand mismatch results in only 70% workforce adequacy for ophthalmology, the second worst among 38 medical and surgical specialties. And that workforce adequacy plummets to 29% when we're looking at rural and non-metro geographies. In my 10 years of practicing in the North Country, I have seen this provider inadequacy increasing firsthand. In 2015, the only ophthalmologist in all of Coos County retired, simply closed his doors, walked away. Together with Androscoggin Valley Hospital, I was able to recruit an ophthalmologist from southern New Hampshire to travel to Berlin 8 times per year to perform cataract surgeries locally. However, travel became burdensome, and he discontinued abruptly in 2021. Unsuccessful to find any New Hampshire replacement for such, the hospital launched a nationwide search to hire a full-time ophthalmologist to help provide the access to care in the North Country. In more than 2 years, they have had one candidate interview in person who then later declined. As such, for years, my patients have had to resort to traveling a minimum of 1 hour to reach a general ophthalmologist where I have one of 2 options to refer to, each of them quite busy with long wait times. When specialty care is needed beyond what these 2 can provide, is 2 to 3 hours for my patients to get there. When I can refer to one of those 2 ophthalmologists, they do not accept all insurances. So in the North Country, that is a great barrier to care. When I cannot refer to one of those 2 ophthalmologists that are within an hour, for many years I have referred to Dartmouth-Hitchcock. That used to be an option. Dartmouth-Hitchcock has closed their outside referrals. They refuse to take my patients because they do not have the providers to take my referrals. They have closed 2 internal referrals. Optometrists within Dartmouth-Hitchcock are not able to refer to certain subspecialties within ophthalmology within Dartmouth-Hitchcock. That is an access issue. The increasing lack of access to care is not just in the North Country. It is statewide. A survey of New Hampshire optometrists found that providers in all areas of the state struggle with between 2 to 6 month wait times for referrals, and many are impacted by the inability to refer to Dartmouth. One of the New Hampshire Medicaid plans has 2 ophthalmology sites in the entire state of New Hampshire that we can refer to because none of the other ophthalmologists take that Medicaid plan. This is all worsening This is not going to improve, and it's going to get far worse with the continued shortage of ophthalmologists. Now, long wait times and travel distances to refer to our ophthalmology colleagues, they're unavoidable. There are many of these procedures that are well outside of our scope and will continue to be so, and we will need to continue to refer to them. However, what is addressed in Senate Bill 440 seeks to reduce the impact of this lack of access to care by permitting in-office procedures that are within the education and training of doctors of optometry. When I was in optometry school 15 years ago, I was educated and trained on these procedures, as that was already part of the standard curriculum back then. I also had the opportunity to do a rotation in Oklahoma, and I directly performed laser procedures on patients. I performed lid procedures on patients. Yet now, 15 years later, I need to refer a patient 1 to 2 hours away from me, despite my education, my training, and my direct professional experience. Despite the amount of time I spend gathering information when I do need to refer a patient, many times additional tests are repeated. A month after I have done them, they are repeated again, and evaluation is repeated. My patients wait months to be seen. They go through duplicative care. They then have to return a second visit 2 to 3 hours away to have their procedure done. They then need to return again for post-operative care. This is a burden not only to the patient, but to their family who must provide the transportation, not to mention the decreased quality of life while they're awaiting their treatments, all of which could be avoided by allowing myself and my optometric colleagues to practice to the full extent of our education and training. As I look ahead to the future for my patients and my practice, I know I will need to hire additional optometrists. I already work with optometry schools and current optometry students, and they want to go live and work where they will be able to fully utilize their training. And while yes, many are still coming here, I all the time have top quality candidates that I want to bring to the North Country who are capable of treating the full scope care that I need to be able to treat, yet they do not want to come here because of the restriction. There are so many reasons to support Senate Bill 440. It reduces patient cost, travel, and wait times by increasing access to care. It increases continuity of care and eliminates duplicative healthcare services. It reduces regulatory, administrative, and legislative burden by authorizing the Board of Optometry to operate as do other independent healthcare professional regulatory boards, and it makes the Granite State a more desirable place for eye care providers to live and practice. On the contrary, you will hear only one argument in opposition to Senate Bill 440, which is a false claim of threat to patient safety. This is false claim because in numerous other states and for 30 years, doctors of optometry have been performing these procedures safely. This is a false claim because the opposition will say that we do not have the appropriate education and training. What they actually mean is that we do not have their education and training. However, that does not make them the only one capable of performing the procedures that are outlined in Senate Bill 440. We simply deserve to perform their procedures that are within our education and training that have been demonstrated to be safe and which will benefit our patients. Some of you may have received a templated email request that you don't water down New Hampshire healthcare. I am here to ask you, don't handicap New Hampshire's healthcare by limiting access to procedures that are within our training and education and have been for decades. This bill specifically excludes procedures that are outside our training and education, and the New Hampshire Board of Optometry will diligently regulate the certification and requirements for performing such procedures, just as other independent healthcare state boards regulate procedures within their profession. In closing, optometry has been a legislative profession, and because of that, doctors of optometry have come before you many times in the past to address restrictions that do not match our education and training. Successful legislation has allowed expansion, and the citizens of New Hampshire have received better eye care for it. None of the scare tactics from the opposition should have come to fruition over the past 50 years, despite their claims of risk to patient safety. Should we be allowed to dilate patients? Should we be allowed to prescribe eye drops? Should we be allowed to prescribe oral medications? Should we be allowed to treat glaucoma? With each successful expansion, we have performed to the highest standards without pullback, without increase in malpractice rates, and without a single disciplinary action. Look at our track record. Optometrists have never let down the legislature or the citizens of New Hampshire. Please vote in favor of Senate Bill 440. Thank you for your time.
Thank you for your testimony. Questions from the committee? One quick one. Senator
Thank you,
Altschuler.
Mr. Chair. Are you turning in your,
Yes.
okay, great.
Absolutely.
I stopped writing all, like, because it was just, there was a lot.
Yes.
So there were a lot of
100%.
good numbers. And I thought, well, maybe she'll just turn it in.
Yes,
We can look
yeah,
at it
we have
later.
them already printed and ready with you. Thank you.
Thank you.
Any other questions? Thank you so much.
All right, we've still got about 8 or 9 more that want to testify, so I'm going to ask everybody, please just hit the highlights and turn in written testimony, because I'm going to have to, I'm going to run out of time here in about 35, 40 minutes, because I do have 3 other hearings to do. So if we can do that, I think we can get through everybody, but I'm just going to ask for your cooperation in that. So Andrew Castamans, sorry, can't quite read the last one.
I brought models.
All right.
All right.
Welcome.
Thanks for having me. Good morning, and what an honor it is to be here. My name is Dr. Andrew Catamaris, and I'm an ophthalmology resident from Dartmouth. I'll start with my background. I received my undergraduate degree at Middlebury College in Vermont before doing 2 years of clinical research at NYU. I then got my MD at Georgetown Medical School, spending my last year focused on ophthalmology research at Mount Sinai and doing clinical rotations at the DC, VA, and Georgetown. I matched into ophthalmology at Dartmouth, which is a 4-year training program. I'm currently a 3rd-year resident. I have about 18 months left in my general training, after which I plan to pursue another year of training in glaucoma. When all is said and done, I'll have gone through, not including research, 13 years of postgraduate training to become an ophthalmologist. I'm here because procedural skills build upon each other, and as physicians, I want you to kind of think about it like the aviation industry. You're not allowed to just get into a plane. You need an experienced flight instructor as your co-pilot to teach, guide you, and save you. Save your butt, as some dramatic videos we've seen online. You need 1,500 hours to fly a commercial jet, and then you're often paired with a more experienced senior captain for years after that. The reason we train so hard is to be prepared for every eventuality. Most folks can hold a plane level at cruising altitude with a little training, but complications like what we're talking about is landing it, as you guys have seen yesterday, on an icy tarmac or in strong crosswinds. Ophthalmology residents get years of one-on-one training. Dartmouth only has 2 residents per year. And these procedures that we're talking about demand many, many repetitions to safely and consistently deliver the best for our patients. Residency is intense, as we've discussed. We work about 80 hours a week. That culminates in a 2-day-long examination called Step 3. Our 2nd year is spent taking call at Dartmouth. We handle all the eye emergencies for the 100-mile catchment area. We take call 1 week at a time, 24 hours a day, 7 days at a time, every other week for a year. We see every gunshot wound, every retinal detachment, every child suspected of shaken baby syndrome, and learning procedures. The other week is spent in clinic with subspecialists. I'm currently in my 3rd year. I still take call on the weekends. I do specific rotations in subfields like glaucoma and retina, and I practice procedures like SLT and eye capsulotomies. In our last year, we're heavily procedural, working with our veterans at the White River Junction VA, the chief of which is here today, and running a chief clinic. Every morning, we have ophthalmology lectures. We attend a journal club that I have to prepare for tonight, and do thousands of practice questions for annual rigorous examinations. I'm here because despite my years of training, these proposed procedures are difficult to master and very consequential if performed improperly. A YAG capsulotomy, I brought a model so I can show you. This is your eye and cross section. The YAG capsulotomy, when we take out the lens in cataract surgery because it becomes cloudy, we put it in a new artificial lens and it's in a capsule. The most grave consequence in cataract surgery is what we call breaking the bag. It's when we drop the lens into the back. A YAG capsulotomy is the use of a high-powered laser to blow a hole in the back of that capsule after the cataract surgery has been completed. We're aiming for a tissue that is 5 microns thick. To put that into perspective, a human hair is 70 microns thick, so 14 times thicker. It can, as one of our residents did, under close supervision, cause a retinal detachment. It's a high-powered laser, so it pulls on the back of the eye, causes a retinal detachment that needs surgery. If you're even too far forward, the laser cracks the lens. The new multifocal premium lenses are incredibly susceptible to that. If you use too much laser, the new lens that we put in falls to the back of the eye, which does happen, and that requires an hour-long surgery that only very specialized ophthalmologists can do, and that's a collaborative surgery between a retina and a cataract surgeon. I've personally performed YAG capsulotomies. I'm here to tell you where I thought I was doing a perfect job, but in fact, I was hitting the lens. And my program director, who was behind me, had to come in and save me. While I've improved, I still need my remaining years to attain competence. And the patients notice. 50% of our brain is dedicated to vision, and they sure as heck know when you've not done a good job. I'm here to tell you how much close supervision of the attending ophthalmologists who've done these procedures, not hundreds, but thousands of times to get us out of trouble and guide our hands. The problem with it, about the models or being, the numbers, is that it's rarely straightforward. I mean, a lot of us could do this on a stationary model, but a patient with Parkinson's shakes. A patient with Alzheimer's looks in different directions. A patient with COPD, of which we have a lot in New Hampshire, they breathe up and down. And so you're hitting a very small moving target with this laser, and it's very hard. It's humbled me, as I hope I've mentioned. We have very strict criteria for the number of procedures we're required to attain licensure, and those do not capture the number of times we've directly observed or performed part of a procedure, and then an attending had to take over. For YAG capsulotomies, the minimum number is 5. However, the average performed nationally in residency is 5 times greater than that. Last year, even the 10th percentile performed twice as many as the minimum, and some residents did over 100 YAG capsulotomies. We need to do these procedures many, many times to attain competence. I'm here to say we need years of close training to land the plane successfully. Thank you for your time. I'd be happy to answer any questions.
Thank you. I'm trying to find that on the list here of exclusions or not exclusions. I'm not sure I even know how to spell that. So
the YAG?
Yeah.
YAG is just
YAG.
the first thing.
All right. Well, I'll have to look for that. But
Yeah.
Thank you for your testimony. Any questions from the committee? And I apologize. I know I'm pushing all of you a little bit. You have a lot of valuable information, and the committee is interested. And I'm certainly, I do want to assure you, we do read our emails in the testimony, especially on this one, because it's a very complex subject for us, and we're all learning and taking it very seriously. Thank you for your testimony. I appreciate it. Thank you. Dr. Nate Lighthizer? Do any of you guys have easy names to pronounce?
Dr. Nate is what I'm known at our
Nate.
College
All right,
of Optometry. Much easier than Lighthizer. Mr. Chairman, members of the committee, thank you for having me. My name is Dr. Nate Lighthizer. I am speaking in support of Senate Bill 440. I'm an optometrist, professor and faculty member, and the director of continuing education at Northeastern State University, Oklahoma College of Optometry. I'm a North Dakota boy, born and raised. Did my 4 years of optometry school at Pacific University in Oregon, and I've been in Oklahoma since 2009, where I received my laser and surgical procedures training. I'm here to speak to you today on a variety of topics, including education and training of these procedures to optometry students during school, as well as doctors after their formal training has been completed. Laser procedures are taught in every single optometry school in the United States. They are part of the curriculum. Students are taking exhaustive courses on these procedures, are participating in hands-on laboratory training, and are being tested on all aspects of these procedures. When you as legislators are told that optometrists and optometry students are not trained on these procedures, that is not true. It may have been true 20 years ago, 30 years ago, but it's not true today. It is a false statement from a political opposition that does not want optometry impinging on quote-unquote their turf. Once again, every optometry school in the country is training students to the highest level of these procedures. I've been doing laser procedures, injections, and surgical procedures in Oklahoma since 2009. These procedures involve YAG laser capsulotomies, laser peripheral iridotomies, selective laser trabeculoplasties, injections of local anesthetics into the eyelid to remove eyelid lesions, styes, etc., etc. These are the procedures that are being discussed in this bill today. I have performed thousands and thousands of procedures, and I oversee students and residents performing these procedures on patients under the supervision of myself and other attending doctors. We have happy patient after happy patient after happy patient, so thrilled to be treated locally by highly skilled and qualified optometric physicians trained at their highest level of their craft. I've been in the room thousands of times for a optometry student and resident's first laser procedure, first surgical procedure, and have witnessed them successfully perform these procedures and help so many patients. No doubt the optometry students today are truly on the cutting edge of technology, education, and training, and are so highly qualified to do these procedures. What if a doctor graduated 30 plus years ago, is in their mid-50s, and didn't get the education and training during their formal schooling that students today are? That's what continuing medical education, CME or CE is for. Just like MDs, DOs, dentists, podiatrists, nurse practitioners, the list could go on and on. Doctors of optometry are required to get continuing education on a yearly basis to keep their skills up to date and increase their knowledge base. I had the 32-hour course known as the Advanced Procedures course, the Ophthalmic Procedures course. You may hear some people call it the weekend course, which has been the training course in every state across the country: Oklahoma, Kentucky, Louisiana, Alaska, Indiana, Arkansas, Mississippi, Wyoming, Virginia. I could keep going. Doctors from all of these states and more have taken this education, which I call the icing on the cake. It is not the only training they get. They've went to 4 years of optometry school and taken rigorous training on the eyes and everything that affects the eyes, and they have successfully implemented these procedures into their practice. I've seen it successfully done time after time in all these states. How successful are they, you might ask? In the state of Oklahoma, where optometry started doing laser procedures in 1988, it's been 36 years in Oklahoma. The Oklahoma board tracked these procedures for the first 15 to 20 years that they were done. In the early 2000s, there were over 50,000 laser procedures done and reported to the board by optometrists with 0 negative outcomes. In Arkansas, where the law started in 2021, optometrists, when renewing their yearly license to practice optometry, are required to report every laser procedure, not just the positive ones, every one. In 2021 and 2022, 2,956 procedures, just shy of 3,000 procedures, have been reported to the board with 0 negative outcomes. In Louisiana, where the law started in 2014, it's been a decade in Louisiana. As of September 2023, 4 months ago, some 25,807 procedures have been reported to the Louisiana board. 0 negative outcomes have been reported to the Louisiana State Board of Optometry examiners by licensees, the doctors, by patients or other members of the public, by insurance carriers, by attorneys, or by anyone else. 0. Optometry is incredibly well trained and positioned to perform these laser procedures and surgical procedures for the citizens of New Hampshire. Political ophthalmology has 0 basis for their claims about patient safety concerns, as the data above clearly delineates. Their motivation and basis for their claims is to protect their turf. As the Idaho Freedom Foundation, which comments and analyzes bills in the state of Idaho, pointed out in an analysis of theirs in a similar bill that's going on right now in Idaho, quote, "There is no reason why a licensed professional who is trained to perform these procedures should be denied the ability to do so, other than the desire of the Idaho Society of Ophthalmology to protect its existing monopoly," end quote. I urge all of you to vote in favor of modernizing scope of practice for New Hampshire optometrists so they can continue to expertly care for the citizens of New Hampshire. Thank you for your time.
Thank you, Dr. Nate. Questions from the committee? That was a lot of info in there. You're going to turn in your testimony too?
Yes.
Thank you. I thought I'd save you the question.
Yeah, no, Mr. Chair, yeah, no, that too. But Dr. Katamaris, did you turn in your testimony? Would you share it with the committee? Thanks. That's it.
And by the way, FYI, mid-50s is now the new mid-30s.
You
so
got
we're
it.
still doing
You
good.
got it. You
Yeah,
got
that
it.
was a little rough. Word to the next testify. Don't do that. Yeah.
Thank you for your testimony today.
Yeah.
Okay, Dane Slentz?
Yes, thank you so much.
Did I get it right?
Yes, you did.
All right, thanks.
All right, so good morning, Senators. I have a simple question to ask you. Yes, Slentz, S-L-E-N-T-Z. So a simple question to ask you. If you or a loved one needed surgery, wouldn't you want the most qualified surgeon to get the job done? And that's what this hearing is all about. My name is Dane Slentz. I'm a board-certified ophthalmologist with fellowship training in oculoplastic surgery. So I have expertise in the areas of the eyelid, the orbit, and the lacrimal gland and tear duct system. I'm here today representing myself and asking you to oppose Senate Bill 440.
As an oculoplastic surgeon, my duties focus on restoring the health and beauty of the eyes and the face. After undergraduate studies, I completed 4 years of medical school, a medical surgical internship, 4 years of medical school, 3-year residency in ophthalmology, and 2 years of fellowship training in oculoplastic surgery. 10 years of training allows you to develop medical decision-making skills and learn invaluable lessons about patient care. This is important in an understated distinction between the training of ophthalmologists relative to optometrists. I'm a fellow of the American Society of Ophthalmic Plastic and Reconstructive Surgery. In your packets, you'll see their statement regarding their position on this bill. And another IPON, I apologize about the extra E added to your name, Senator Pearl.
It was a Pearl Vision.
In fellowship, I performed 3,100 super real patients in the middle of the COVID-19 pandemic. This is about 3 to 4 times more than the minimum required. Standardized surgical training is critical to being a competent surgeon. These are skills that you cannot learn in a 32-hour course, on a simulator, in an externship, or by practicing on each other. All procedures are associated with risk, and no surgery is ever predictable. Ophthalmologists are medical doctors trained in surgical technique and management and complications should they arise. The eyelid skin thickness is 1 millimeter. That's the same as a credit card. While performing an injection of local anesthesia, a Kentucky optometrist penetrated a needle through the eyelid and into the eye. This is a serious complication that can lead to blindness or the need to remove the eye, and that letter from the Kentucky board is in your packet as well. When optometrists cannot manage their own complications, the patient will be referred to an ophthalmologist, perhaps when it is too late to save their vision. Expansion of surgical scope to optometrists will not improve access to quality care. In this bill, optometrists are asking to remove lesions not suspected to be cancerous. Missing cancer is a devastating outcome that may lead to removal of the eye or death. Here I show you a picture. This picture on top is an abscess of the tear duct. Although similar in appearance, the picture on the bottom is an invasive squamous cell carcinoma. He is currently undergoing multiple rounds of reconstructive surgery due to this condition, and he might end up losing his eye. Believe it or not, he didn't need opioids in his postoperative therapy. The last opioid prescription I prescribed was in 2021. The top picture here is a sty. This is also.
Would you mind passing those around so we can have a closer look? Thank you.
The top picture here is a sty. A sty is one of the lesions that tend to be benign and that optometrists are asking for. Although similar in appearance, I imaged this patient on the bottom, and instead I found an extensive tumor that invaded her eye socket. An optometrist in Tennessee, where they can perform eyelid surgery, was managing this chalazion that they thought for months before referring to an ophthalmologist, who performed a biopsy and diagnosed basal cell carcinoma. Senators, you only have one chance to do it right the first time. The language in Senate Bill 440 is dangerous because it leaves the door wide open for optometrists to perform numerous eyelid procedures, including skin defect repair, repair of an eyelid that is turned inward or outwards, eyelid reconstruction, and placing implants into the eyelid. These are specialized procedures in which ophthalmologists will typically refer to their oculoplastic colleagues to repair. Optometrists say that they don't want to operate on the bony orbit. However, it doesn't say that they can't operate in the orbit. A bleed in the orbit is an emergency and requires prompt treatment that, if untreated, can lead to blindness. Interestingly, the bill specifically excludes surgical treatment of blepharochalasis. This picture up top is blepharochalasis. It is a rare form of recurrent swelling of the eyelids. You typically don't operate on this. In contrast, and probably what they meant to say, is dermatochalasis. Dermatochalasis on the bottom here is a thin, stretched out skin that can be operated on, if indicated. The wording in this bill is concerning because it demonstrates that optometrists don't understand the proper medical terminology for oculoplastic conditions, yet they wish to operate on this. Although he presented me for the droopy eyelids, I chose not to operate on him because of this pigmentation here in his eye. This is melanoma until proven otherwise, and missing this diagnosis would be lethal. So senators, I ask you again, if you or a loved one needed surgery, wouldn't you want the most qualified surgeon? The citizens of New Hampshire do not deserve the substandard medical care that this legislation represents. I urge you to consider the welfare of the citizens of New Hampshire and vote no on Senate Bill 440. Thank you.
Thank you for your testimony. Question? Just a quick one, please.
Thank you. Thank you for taking my question. I'm not sure if you've seen the amendment, but it's, it's nominal in its change. In reviewing the bill and the exclusions, is it your testimony that there are exclusions that are missing from this list?
Correct. In response to the eyelids, what I
Got that one right? You got it. All right. There are no Bob, that one right? You got it. All right. There are no Bob Smiths on the list, by the way.
Yeah, I'm gonna.
Just so everybody knows, this is a
Try not
challenge.
to take issue with the mid-50 thing, because I'm past the mid-50s. Thank you guys for allowing me to speak with you this morning. I appreciate your time and your service to the state of New Hampshire. I don't know how you guys do it. I am Dr. Dorothy Hitchmoth. It's always been an honor to provide testimony on behalf of the people I serve and care for in New Hampshire. To be clear, I am here to firmly advocate for improved access and quality health care, especially for those who have complex medical eye conditions and associated diseases of the body. I'm here to support your fact-finding efforts on behalf of the safety of my patients. There is no other reason that I am here. My testimony will be brief. I know you've heard from a lot of people this morning, and I appreciate that patience. But I hope to lay out my background a little bit so that you can call on me if needed after the hearing. So I'll try to keep it short. I've been in practice in rural New Hampshire for 28 years. I'm VA and residency, VA and fellowship trained, dual board certified. I'm a professor of both optometry and medicine, and was the chief of optometry at the VA Medical Center in White River Junction for 22 years. I currently own a private practice and run a consulting firm that specializes in the development of medical devices that help prevent vision loss. I'm also a researcher and editor and have published dozens of scientific articles, book chapters, and guidelines on a variety of eye and related diseases of the body. I'm on the board of trustees at the New England College of Optometry, and I have taught medical and optometry students and residents for over 2.5 decades. I have intimate knowledge of their respective curricula and clinical training programs. Lastly, I am a consultant for the Accreditation Council on Optometric Education. ACOE is the accreditation body that ensures uniformity and modernization of classroom and clinical training at all schools of optometry and their affiliate intern and residency programs. I'm here to assure you that there's nothing in Senate Bill 440 that's not included in the curricula, as my colleague, Dr. Nate, so eloquently laid out. Furthermore, legislators in New Hampshire, Vermont, and other places have previously, and I've been in front of you many times as a body over many years, 20 plus years ago, I was here when we passed all the prior bills. And yes, the sky has not fallen down, and we have not killed and maimed people left, right, and center. But I am here to unmistakably repeat respective equivalencies and training. Also, please remember, and this is an important point, and I will be handing in my testimony, that specialty clinical training occurs years earlier in optometry school because we know we're going to specialize, and it includes a human body systems approach that results in competency in the treatment of eyes and related diseases upon graduation. It's very similar to dentistry. This is why my colleagues in ophthalmology must complete a residency because they have very little training in eye disease prior to medical school graduation. I think all of them would affirm that, and I have certainly witnessed it. I testified, as I said, several times in front of this body over the 28 years regarding scope of practice because New Hampshire laws were outdated and continue to remain so, and we have to come back over and over of a career Army veteran who served 3 tours in Vietnam. I am the wife of a career Air Force veteran, and my middle son just completed 7 years in Army intelligence. I can assure you that if I thought the VA was wrong in their repeat suppositions and directives mandating that all doctors practice at their highest level, I would be the first to speak up loudly in opposition. Contrarily, the VA and the U.S. Department of Health and Human Services have long recognized that doctors of optometry are competent, well-trained, independently licensed physicians and provide a much-needed core service to our nation's finest. I affirm they do not have this wrong, and I'll leave that at that. I'm also here to inform you that despite the opposition from the Medical Society, scope of practice laws were passed both in New Hampshire and across the country, and thousands of patients have been well served.
now for almost 3 decades. I have a direct witness to your good work in this regard. Patients have not been harmed, and we continue to improve access and good care. And let me just say also, the bill doesn't cover incompetence. Anyone can not practice as they should. We have mechanisms in place for these kinds of things. And I wasn't going to bring this up because it's very personal, but one of those pictures that I saw, the patient had a sebaceous cell carcinoma. It's deadly. My own father was not diagnosed properly with that condition. It was missed. I went to see him because my mom called and said, hey, there's something wrong with your dad's lid, so-and-so. It was, and he subsequently passed away. So I don't talk about that much in public, but that is a matter of mistake, incompetence, you choose, right? Things can go wrong. Every single doctor, even those who have been properly trained, can make mistakes. Okay, that's not what this bill is about. And let me just be clear on that. You know, what I would like to do, and what I hope the bill ultimately will do, will eliminate the friction that you've heard today. We must get on the business of advocating for our patients, and quite frankly, together. To do this, the rules governing optometry should be no different than those governing medicine, and that is ultimately what this bill is about. The State Board of Optometry should set the rules and provide patient protection from a position of expertise based on the actual training of this very dedicated group of doctors. I think it's unfair and inefficient to ask the New Hampshire legislature to try to keep pace with all medical advancements, and hope you will support this bill moving forward. I would respectfully underscore that no medical profession stands still. There is no monopoly on knowledge, and optometry has a solid national board certification system, uniform training, a strong independent accreditation agency, and state licensure systems designed to protect the public. Today, we are asking that you work in the spirit of New Hampshire's effort to attract the best and brightest doctors to our state. We must be able to compete knowing that we have a broad doctor shortage, as you've heard over and over this morning. In a few moments, you will hear from my associate, and we'll learn what happens or what can happen when there's a lack of modernization in the Practice Act. And finally, I'm happy to act as a resource to this body and anyone else who, quite frankly, without conflict of interest, works towards my own practice mission, which is the prevention of vision loss and blindness. And I thank you for your time and consideration.
Thank you for your testimony. Questions? Seeing none?
Yeah.
Yeah, please turn in your testimony. Okay. So I have 5 more people wanting to testify. If everybody can do this in like 2 or 3 minutes, I think I can get you all in. So let's just try and be succinct if we can. Sonali Desai?
Sonali Desai.
All right.
Thanks, yeah.
Welcome.
Thanks. I appreciate the opportunity to speak to this committee. Glaucoma is a disease that causes
Could you please give your name for the record?
Oh, Sonali Desai. Yeah.
Thank you.
Glaucoma is a disease that causes irreversible blindness. It's projected to impact 118 million people by 2040. The cost of treatment's about $6 billion per year. Increasing utilization by non-surgical optometrists will really drive up the cost of that healthcare. I'm Sonali Desai. I'm a board-certified ophthalmologist and glaucoma specialist, and I practiced in Nashua for the last 18 years. Like my colleagues, I went to medical school, did an internship in surgical residency. I did 3 years of ophthalmology training, and then an additional year of surgical and medical glaucoma training. Optometrists propose treating glaucoma with laser surgery. Laser surgery is generally performed by a skilled surgeon. It involves technically placing a focusing lens on the eye, identifying correct anatomy, the ability to adjust the laser and apply the laser energy to targeted tissue. The experience, though, to manage all possible complications is the biggest issue here. Ophthalmologists have been certified in residency programs with direct one-on-one training by skilled surgeons that occurs over many years. Laser is never a minor procedure. And so as my colleague before referred, optometrists can complete this training in 32-hour weekend courses. The American Glaucoma Society reports that this is insufficient training.
An average glaucoma fellow performs 200 types of glaucoma surgery and laser procedures in a single year. I've actually worked very closely with optometrists and have much respect for their profession. However, I do find that they often are unable to correctly diagnose medical conditions and types of glaucoma. Not all glaucoma responds well to these lasers. I recently had a primary care physician call me to discuss a case of glaucoma managed by an optometrist over many years. Things didn't seem right to her. And upon evaluation, the patient didn't have glaucoma at all, but had a brain tumor that was misdiagnosed. They haven't attended medical school, so they don't have the knowledge to diagnose these conditions. Thankfully, though, they couldn't perform laser yet. How do you subject a patient to a procedure if you don't have the medical experience to have a proper underlying diagnosis? And this is exactly what happened in Kentucky. I'm going to read you an excerpt from the Kentucky Eye Physicians and Surgeons, who firsthand dealt with consequences of legislation. An optometrist encountered a patient with acutely high eye pressures in the office. An optometrist performed a peripheral iridotomy on a patient. The patient did not have narrow angle, but had neovascular glaucoma. This type of glaucoma is not treated with the type of laser procedure they performed. They actually delayed the patient's care, worsened the glaucoma damage. This case of misidentification of disease resulted in worsening of the condition. And the condition at hand is potential blindness. The Journal of the American Medical Association published a peer-reviewed study that showed that the SLT performed by optometrists were more than 2 times as likely to need repeat procedures rather than an ophthalmologist. This law will harm patients with unnecessary and ineffective procedures. So I'm just going to go quickly, but Section 4, Part B, optometry wants to perform anterior chamber paracentesis in the event of acute glaucoma emergencies. Anterior chamber paracentesis involves piercing the full thickness cornea and entering the front of the eye with a needle or a scalpel. I rarely perform this procedure in the office in an acute setting for glaucoma, frankly, because it's not permanent and there's better procedures. As ophthalmologists, we all have access, immediate access to our operating rooms within surgery centers.
I got to ask you to wrap up real quick.
Okay.
Thank you.
We can perform more effective procedures for acute glaucoma. So I would just leave you with, there's many complications. We're all horrified as we saw images of the 737 MAX flying with passengers inside with a missing door. Perhaps it's because a novice engineer or a technician that didn't properly tighten bolts. After this disaster, the FAA established an independent organization to certify the safety of these flights. And just like the 737 MAX, this bill lacks oversight. No member of the Board of Optometry has ever gone to medical school, performed surgery, and it's difficult to imagine that the New Hampshire legislature would put non-surgeons in charge of overseeing surgery.
Thank you for your testimony.
Thank you.
Dr. William, oh boy, I don't know if I got this last one. Genshine?
Gensheimer, yeah.
All right. Again, I'm going to ask it, just please hit the highlights and turn in written testimony. I am running out of minutes here.
Understand. I'll try to be brief.
Thank you.
And thanks for your patience this morning. Good morning. My name is Dr. William Gensheimer. It's great to be with you, and I'll try to keep my testimony brief. I'm the Chief of Ophthalmology at the White River Junction VA Medical Center. I'm also the Chief of Cornea at Dartmouth-Hitchcock Medical Center and an Associate Professor of Surgery at the Geisel School of Medicine. Again, I'll try and keep this brief. I'm testifying this morning as an eye surgeon advocating for patient safety. My views do not reflect those of the United States government, Department of Veteran Affairs, or the White River VA. The first thing I want to say briefly, I have a strong interest in resident surgical training and microsurgical training. So I've trained residents at Georgetown, Walter Reed National Military Medical Center, and now Dartmouth-Hitchcock. We've performed hundreds of procedures together and have co-authored the American Academy of Ophthalmology's book on surgical simulation, as well as published on resident surgical education. So point number one, there's no such thing as a simple surgery. There's no such thing as a simple laser. To quote Bill Belichick, there are no shortcuts in building a team. You build the foundation brick by brick. So with resident surgical education, you build the residents, you teach them step by step with close mentorship. I think it should be said that in claims about complications, you need to dig into that with a grain of salt. Remember, if there is a complication that happens, those are referred to ophthalmologists for subspecialty care. So I'd be wary of claims about the lack of complications. Remember, those are referred for subspecialty care by an eye surgeon or an ophthalmologist. I want to make a second point about VA policy. VHA Directive 1121 defines the scope of practice for ophthalmologists and optometrists in the Veterans Health Administration. Ophthalmologists are defined as surgeons that can perform surgery and lasers. The scope of practice within the VA, as defined by VHA Directive 1121, does not allow optometrists to perform lasers, procedures, surgery, intraocular injections, or intravascular injections. And as an Air Force veteran and the Chief of Ophthalmology at the VA, it's important to know that veterans do not receive a second standard of care. They receive the highest quality care, and they earned it. Third point, access to care. The Dartmouth-Hitchcock Ophthalmology Residency Program will be graduating its first residents this year. The residency program recruits new ophthalmologists to the area in two ways. First, it brings in high-quality ophthalmic surgeons. So in the next 9 months, there'll be 3 new faculty at Dartmouth-Hitchcock. So a lot of the questions or concerns about access, specifically in the North Country, will be addressed by the 2 new added retinal surgeons. Also, when you train residents, they develop these local ties within New Hampshire, and they want to stay within the local area. So as we graduate residents every year, some will stay within the local area. So the right way to increase access is to have eye surgeons doing eye surgery, and by training our own, which is what we're doing at the residency program. I want to keep my statements brief. You're always welcome to reach out to me with any questions or concerns, and invite you to actually visit us to see what an eye surgery or an eye procedure is. We'd love to show you.
Thank you. All right, Nancy Efferson Bonisher? I think I'm killing this one, sorry. Bonisher? Sorry about that. I think
That's
I killed
okay.
your last name.
It's those hyphenated names. I'm Nancy Bonachea. I'm a vitreoretinal specialist, which is a type of ophthalmologist that subspecializes in the back of the eye, basically diabetes, macular degeneration, retinal detachments, etc. I'm going to keep my comments extremely brief. I want to comment on this bill with respect to the modifications to the existing scope of optometry with respect to injectables and medications and dyes. One of the things of this bill is to permit optometrists to inject dyes into the arm through the venous, intravenous, in order to do presumably imaging, diagnostic imagery. Retina specialists use dyes for imaging of the back of the eye. Fluorescein angiography, what we call ICG. Those dyes are to help us diagnose and treat retinal diseases. And yet, optometrists are not asking, nor are they currently trained to treat retinal diseases. These dyes have adverse effects. If a person has a severe reaction, they can die, basically. And there's absolutely no reason why an optometrist, or for that matter, a cornea specialist who's an ophthalmologist or an oculoplastics, would want to do one of these studies when they're not trained to interpret them nor treat them. So it bothers me to think that individuals who are not medical physicians or surgeons have the ability to perform systemic interventional diagnostics that could have very adverse effects when there's absolutely no reason to subject patients to that kind of danger. That's it.
Thank you for your testimony.
Any questions?
Andrew Katamaris?
No, he's already spoken.
Oh, you did speak. Oh, I guess I missed that one. Yep, all right. Dr. Jessica Eid? E-I-D? Eid?
Okay, it looks like this is already on. Thank you so much for the opportunity to speak with you today. My name is Dr. Jessica Eid. I'm an optometrist that practices in New London, New Hampshire. I just wanted the chance to tell you a bit about my background and how I practiced before coming to New Hampshire. I grew up in Texas and Kentucky. I attended optometry school at the University of Houston. During my time in optometry school, I spent years managing complex medical eye conditions. During that time, I treated patients in Texas, Louisiana, and Oklahoma. I then completed a residency in ocular disease and ocular and refractive surgery in Tulsa, Oklahoma. I chose that residency specifically because Oklahoma was a state where I could continue to gain experience performing surgical procedures and laser surgeries of the front of the eye. Following this residency, I began practicing in Kentucky because this was a state where I could continue to practice to the full extent of my education. Now, my husband and I moved to New Hampshire for his job as a general surgery resident. If it were not for his job here, however, New Hampshire would never have been on my radar, as it is not a state where I can practice to the full extent of my training. While I have grown to love New Hampshire with all of my heart, and I hope to stay here for good, staying here is not the best decision for my career, as I am limited in how I can care for my patients. I cannot tell you how many times I have seen a patient who has needed one of these minor procedures in order to preserve their vision, and I've had to tell them, I have done this procedure countless times. I could do it for you right here today. However, the state of New Hampshire will not allow it. Instead of being able to help them, I have to refer them to an ophthalmologist, which in the best of cases results in a delay of care, which can threaten their vision. In the worst cases, patients do not have the transportation means to get to an ophthalmologist, especially given the rural nature of our state and of my practice. This is becoming more and more of a problem as ophthalmologists in our region are so busy that many will not accept new patients, and so we're having to refer them even farther away. The problem is getting worse. A solution is so obvious. Allow us to practice the way that we are trained. In my case, allow me to practice in New Hampshire the same way that I have practiced in Louisiana, Oklahoma, and Kentucky. If New Hampshire wants to attract the best doctors to the state and to take the best care of their residents, it is imperative that we are allowed to treat our patients to the full extent of our education. Thank you so much for letting me share my story.
Thank you for your testimony. All right, that is all I have on the list. I do have 11 more that signed in opposed, and if anybody else wants to give testimony, I'm going to ask that you submit it to the committee by email. And with that, I'm going to close the hearing on Senate Bill 440.
Okay, you're all set. We're going to open the public hearing on Senate Bill 318 FN and recognize the prime sponsor, our own Senator Pearl. Good morning, Senator.
Good morning. Well, and thank you for having me in today. I guess I was here earlier, but for the record, my name is Senator Howard Pearl, representing District 17, and I reside in the town of Loudon. I am here today to introduce Senate Bill 318 relative to the adoption of the Social Work Licensure Compact. I've got two compacts that are coming before the committee today, and the main reason that I'm bringing them forward is we're all aware of the shortage of workforce that New Hampshire is experiencing in many areas, in fact, nearly every area. And these compacts, I feel, help to create portability within the licenses that allow new workers to come in and help in these very vital areas. And this one, 318, is to do with social work. And I know there's a real shortage of services in this area in the state, so I am introducing this bill to hopefully help resolve some of the workforce issues that we're seeing in this area and help people get the diagnosis and care that they need. I'm going to ask the chair to call up Director Lindsay Courtney next, because I'm going to let her explain the mechanics of how the compacts work. And so with that, I will ask the committee to take a good look at this and hopefully be able to support the compact. I guess my one final thought is, as you know, with compacts, we have to accept the language as it is in order to participate in the compact. So our opportunity to make amendments to any of these compacts is essentially very negligible. I guess there's minor tweaks we could make, but we essentially have to accept the language as it is. So just something for the committee to have in mind as we listen to the testimony. Thank you.
Thank you very much for your testimony, Senator. Are there any questions for the Senator? Okay. Seeing no, thank you very much. The chair will call Director Courtney.
Thank you, Madam Chair, members of the committee. Lindsay Courtney, Executive Director, Office of Professional Licensure and Certification. And I wish to thank Senator Pearl for bringing this bill forward. The OPLC fully supports Senate Bill 318 relative to the adoption of the Social Work Compact. I had the pleasure of working with the Council of State Governments to draft this bill, so I'm happy to answer any questions you may have. But just generally, as the committee is aware, there are two compact models. The first model allows the home state to issue one license, and you're able to practice in any compact state. That is the model that we've used in New Hampshire for nursing, and it has really helped with workforce in terms of allowing people to come here, practice immediately without having to go through the state to get approval. The second model is a privilege to practice model, and this is the model used by a lot of other compacts. And what it does is it authorizes you get issued a compact license, and then you have to get issued a privilege in each state you wish to practice. Both models serve the same goal, which is to allow somebody to obtain licensure or authorization to practice quickly so that they can work in other compact states. But there are two different models, and one provides a little bit more oversight of the regulatory body from the licensure process. So this proposed model is the first model. This is modeled after nursing, and there were extensive conversations at the drafting committee about whether we should use this model versus the privilege to practice model. But ultimately, in order to provide for better portability and reduce administrative and the costs on the licensee, we opted to draft this in the similar to nursing. So a lot of this language is essentially, I don't want to say canned language, but it's language that we find in every other compact. I would just draw your attention to Section 3. That sets forth the requirements for the state to participate in the compact, and Section 4 sets forth the requirements for the licensee to participate in the compact. And so if we were to adopt this piece of legislation and enter the compact, New Hampshire would be eligible to participate in the compact. And this compact is different from other compacts in that there are 3 categories of licensure that are proposed. We would be able to enter the compact with any of the categories of licensure that we, for which we meet the criteria, and we currently meet the criteria for 3 categories. On Section 4, that concerns what a licensee has to do to enter the compact. And so I think it's worth noting that even if the state were to adopt the compact, there's always a single state licensure opportunity. There are always 2 pathways to licensure. One is through the compact, and one is through the single state. And the boards are free to make changes to their laws and to their rules regarding the single state licensure. And then finally, I would note that on the element of public protection, we've had a lot of questions and comments regarding universal recognition of licensure, the reciprocity bill from last year. Why should we adopt a compact? I will say that HB 594 made some great strides in allowing for portability, but what it doesn't do is allow for information sharing between the states as it relates to discipline. And so the compact, it promotes public protection in that sense. We are required to use a data information exchange. We use them in the other compacts, whereby if somebody is under investigation, we are able to notify the other compact states, and that state is eligible and able to take action if they choose to do so. So I think it's very protective of the public in that sense as well. With that, I ask for your support of Senate Bill 318, and I'd be happy to answer any questions.
Thank you for your testimony. Questions from the committee? Senator Altshuler.
Thank you. Thank you, Dr. Courtney. So could you, I have 2 questions. First, with what you just spoke about, the discipline information can be shared. Did I hear you correctly? You said if there's a pending investigation, that information is shared between the compact states?
Yes, so the statute requires that we share, quote, significant investigative information, end quote, with the other compact states. In nursing, we refer this to the red flag situation, where we go into the database and we put a red flag, and other states can reach out and we can provide that information. It's ultimately up to each state whether they do consider it to be significant in order to share, but we are required to do that.
Okay. And follow-up?
One follow-up? Yep.
So in Section 4, could you elaborate a little bit on the the pathways for someone who is, pursuing their social worker's license? And you had said that there's two pathways. One is just to become licensed here in the state of New Hampshire. And did I understand correctly that that does not automatically give you entrance into the pact? You have to then subsequently apply to that too? Could you just go through that one more time? Because that
Certainly.
one I found really confusing.
Yes.
Yeah, this part.
So I should note that in order to receive a compact license in New Hampshire, you have to be domiciled here. And so if you are, let's say, licensed in Massachusetts or you live in Massachusetts, you would not be eligible for a New Hampshire compact license. And under that scenario, you would just apply for a single state license. You wouldn't be able to use that license to practice anywhere else. Practically how it works, this is how it works with nursing, and that I had anticipated it would work the same way here, is the individual submits one application and they note whether they're applying for a compact or a single state. If they're applying for a compact, they have to show proof of their domicile, typically a driver's license, but some other document will suffice. And if they qualify, we issue the compact license. If they don't, we issue the single state license. That's typically how it works.
One more follow-up?
Yeah, so I guess, so I'm looking at section 4 on page 5, and I see the mechanics of getting involved with the multi-state license. Why would anyone not, like, why wouldn't we have just the multi-state, and what would be the advantage to having two pathways for a single state and a multi-state versus entering everybody into the compact? That's what I'm struggling with.
So that's a very great question, Senator. So the compact is intended, I mean, it's a compromise because all states are agreeing on the same criteria.
Right.
It's certainly, so there are some states that if you look at their existing state licensure requirements are not as much of a high bar, if you will. And then there are other states that are a higher bar. So some states may want to experiment with different licensure requirements that don't necessarily meet the compact, and they want to retain that authority to do so. The other reason I would say is for those people like Massachusetts. Massachusetts is generally not a compact-friendly state. And so people who live in Massachusetts, work in New Hampshire, they wouldn't be eligible for a New Hampshire compact license, and we would need another option to get them licensed so that they could work here. That's another example.
All right, one more.
Yeah, thank you. So this is the sticky part for me. So if you, I understand because we went through this, last year with not wanting to lower the bar of our own standards and the boards across, OPLC, that we wanted to have the highest standards we can have to serve the people of New Hampshire. So in entering this compact, are you saying that other members of this compact have lower standards than New Hampshire in achieving a social worker's license? Is that?
No, they're all agreeing to the same requirements. And I would note also our Board of Mental Health Practice fully supports this adoption of this compact. What I'm saying is some states, for state sovereignty, if you will, like to retain the authority to have other pathways. For example, they may grandfather in certain social workers. I think Wisconsin is a prime example. People who, if there wasn't a previous licensure requirement, but you've been working for 30 years, they're going to grandfather them in and say, you're eligible for a license. Those people don't fall under the compact because,
okay.
You know what I mean? So, okay.
All right, that makes entirely more sense. So this minimum standard that is outlined here, is it safe to say that every state within the compact also has a dual entry, like I'm only going to work, I can get just the Massachusetts license or the Mass and compact?
Correct.
And we'll be doing, okay, and that makes so much more sense. Thank you so much.
Further questions? Senator Carson.
Thank you, Mr. Chairman. Good morning.
Good morning, Senator.
I'd like to bring your attention to page 15, line 33, concerning the data system. As you know, we have a constitutional amendment speaking to privacy. And here you're talking about the collection of information. And I just kind of had two questions, Mr. Chair. I'm looking at line 36, where it says the commission shall assign each applicant for multi-state license a unique identifier. And then if you look on the next page on line 16, on line 4, beginning on line 1, the member state shall submit uniform data set on all individuals, and then it goes on to say identifying information. It seems that there might be a conflict there, because again, it is our responsibility to protect individual information, and I don't know if that might need some clarification. I'm just throwing that out to you. Do you think it should have some clarification involved?
I think we can certainly clarify. I don't think we can change the language, unfortunately. Other states have already started to adopt this, and it would render us ineligible for the compact. What I will say practically is what that means is rather than using a social security number to tie people together, they're going to assign a random number so that we know, 595 is Lindsay Courtney, and that the identifying information is typically publicly available information, such as your name. It also includes non-publicly available information, such as your address, other non-publicly available information, and then licensure information. So that's typically what that means. And on the back end, when we go into the data system, for example, nursing, if I pull up somebody's record using their unique identifier, I can see their history of licensure in every state and whether a state has taken action and why they've taken action, and their history if they were an LPN and they're now an RN. That's the kind of data we're talking about.
Okay. May I follow up? Thank you. It's that this information is going into a national database, and I did notice here on I think it's line 24 on page 16, it says member states contributing information may designate information that may not be shared with the public without the express permission of the contributing state. Do we have your assurances that New Hampshire will stand and say, you cannot share that information?
Certainly, we will certainly conduct an analysis as to what is publicly available, and if it's not publicly available, we will designate it as non-public.
One last question. When they're talking about here, again, on page 16, about significant investigative information, as you know, people will file complaints and they'll put a lot of personal information, especially the person who's filing the complaint. How do we make sure that we are protecting their information as well as the information concerning the social worker against whom a complaint has been made?
So a lot of this will be fleshed out in the Compact Commission rules, but practically we don't input data regarding the complaint into the system. So in nursing, and I'm just assuming it would work like nursing, there's a red flag. And in New Hampshire, we can't share investigative information with just random people. We have authorization to share with other regulatory bodies, but we don't input the information into the system. We just raise a red flag. And another regulatory body can reach out to us, and then we can share that information with that regulatory body, and under certain parameters that it not be subject to additional disclosures.
Okay, thank you very much.
You're welcome.
Is that a standard operating practice for most all light compacts?
Yes.
Okay, thank you. Further questions? Seeing none?
Thank you for your time.
Appreciate it. Melissa Willett. Good morning, welcome.
Thank you very much. Mr. Chairman and honorable members of the committee, the Department of Defense is grateful for the opportunity to support the policies proposed in Senate Bill 318, which addresses licensing issues affecting our service members and their families. My name is Melissa Willett, and I'm the New England Region Liaison for the United States Department of Defense State Liaison Office, operating under the direction of the Undersecretary of Defense for Personnel and Readiness. We represent the Department of Defense and establish relationships with state leaders across the country who are concerned for troops and their families' welfare by harmonizing state and federal law on policy problems of national significance. These are identified by the Office of the Secretary of Defense, the military departments, and the National Guard Bureau as areas where states can play a crucial role. To address license portability for military spouses, states have turned to occupational licensure interstate compacts, which streamline relicensing between member states of a compact for all practitioners in an occupation and provide specific support for military spouses of relocating active duty personnel through provisions recognizing unique requirements of military life. Taking care of our people remains the top priority of the Department of Defense and is at the center of our national defense strategy. Military spouses provide the strong foundation upon which their loved ones in uniform stand, and both our communities and nation rely on their resilience. To further expand employment opportunities for military spouses, the Department has been directed to accelerate the passage of interstate licensure compacts to ease the burden for spouses who must go through the often challenging and frustrating process of transferring their professional licenses with each move. Frequent moves and cumbersome licensing and certification requirements limit career options for military spouses. Removing these barriers, creating reciprocity in licensing requirements, and facilitating placement opportunities can help a military family's financial stability and speed the assimilation of the family into its new location and create a desirable new employee pool for a state. With the above stated benefits in mind, we look forward to engaging in efforts that will create increased quality of life for all populations we aim to serve. We appreciate the opportunity to provide comments on the policies included in Senate Bill 318 and thank the bill sponsor for introducing this legislation. On behalf of the Undersecretary of Defense for Personnel and Readiness and the Deputy Assistant Secretary of Defense for Military, Community, and Family Policy, I'd like to thank you for your time and look forward to the positive outcomes of these policy changes.
Thank you for your testimony.
Thank you.
Questions from the committee? Seeing none? Thank you. Lynn Stanley.
Good morning.
Good morning. Welcome.
Thank you. Thank you, committee, for hearing my testimony. Thank you, Senator Pearl, for introducing this legislation. For the record, my name is Lynn Currier Stanley. I'm the Executive Director of the National Association of Social Workers, New Hampshire chapter. I'm also the Executive Director for the Vermont chapter, licensed independent clinical social worker here in New Hampshire, and I live in Pennacook. I'm delighted that Department of Defense is here today testifying. It's the U.S. Department of Defense that brings forth the grants to write the model legislation because the spouses of our military, our service members, are some of the most underemployed people in our workforce. And so for the last, for over a year, the table was set with NASW, ASWB, Director Courtney, to write the model legislation. And one of the things that I'm particularly happy about is that it is a multi-state compact as opposed to privilege. This means that the social worker doesn't have to have an additional cost for all of those states that they might practice in. Also, if all of a sudden your client is in a different state, going through that process to get privilege kind of negates the immediacy of crisis intervention. We are strongly supporting this bill because it does, it benefits the social worker, the local agencies, state agencies, community service agencies, and our clients. It helps the social worker because right now we have many social workers who are licensed in New Hampshire, in Massachusetts, in Maine, in Vermont. We have, they have clients who go to Arizona, Florida, certain times of the year, so they get licensed there. This comes to be very expensive, first in the initial licensure, relicensure every 2 years in most states, and then each state has their own requirements for continuing education. And so keeping track of the 12 CEs of domestic violence you need in Maine, the cultural competency CEs you need in Vermont, the 3 in suicide prevention in New Hampshire, and then everybody's got different ethics CEs, keeping track of all of those, and all of those come with a cost. It helps our agencies because if somebody is licensed in another state, is part of the interstate compact, and then moves here with the job at one of our agencies, they get a grace period and are able to practice immediately, as opposed to waiting a couple months where either they can't work or the agency can't get paid. They can't bill insurance until they are licensed here to practice. There'd be that grace period, and now that New Hampshire is their home state, then they can go through the process of switching over their license to New Hampshire. Most importantly, it helps with client care and continuity of care. If you think about the young person coming up from North Carolina to go to UNH, they're receiving mental health services from their clinician in North Carolina. Unless that person is part of the interstate compact, they can't practice here in New Hampshire. That person will be able to continue to see their clinician. Same with the student from New Hampshire who goes to UVM. They'll be able to continue to see their clinician here. The person who goes away for several months during the winter, business trips, whatever brings them to another state, they'll be able to continue seeing their social worker without a gap in care, or that social worker having to make some tough decisions about whether or not, how much in crisis is their client and how much can they push it. At this moment, I was just looking at the social work compact map. There are 22 states who have introduced legislation, and we expect that number to go up in the next few months. We have a number of states that have year-long legislative sessions, so we expect that to go up. New Hampshire is already is already a part of the psychology compact, the mental health counselor compact, and we hope that the social work compact will go through. And that's my testimony, and I'm happy to answer any questions you might have.
Thank you. Questions from the committee? Seeing none? Appreciate
Wonderful.
your testimony.
Thank you.
Holly Stevens from NAMI. Good morning and welcome.
Good morning, Chairman Pearl, members of the committee. My name is Holly Stevens. I'm the Director of Public Policy for NAMI New Hampshire. NAMI is a non-profit grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. On behalf of NAMI New Hampshire, I'm here today to speak in support of Senate Bill 318. One of our biggest reasons for supporting this bill is because of the workforce shortage, so I won't go into details on that. But I did want to provide just some numbers of folks in New Hampshire who are affected by mental illness. 1 in 5 adults and 1 in 6 youth aged 6 to 17 experience a mental illness each year in New Hampshire. In 2021, nearly 40% of adults in New Hampshire reported symptoms of anxiety and depression, and 17% of those folks were unable to receive therapy services. Of the 70,000 adults in New Hampshire who did not receive mental health services, 41% of those was due to cost. We also know that folks in New Hampshire are more likely to have to go out of network for their mental health care at a rate that's a lot higher than primary health care. We have had folks call our information and resource line. They have private commercial insurance, and their insurance has given them a list of 20 plus people to call for therapy services, and they've gone down that list and called every single one of them and been told that nobody's accepting new patients, One of the things that we have seen is there are a lot of providers in the state who have decided not to accept insurance at all due to the fact that they have a lot of folks that are willing to pay cash for their services, and they don't have to deal with negotiating contracts or the administrative burden of billing out insurance and waiting for the payment to come in. When individuals with mental illness receive the right services at the right place at the right time, fewer folks end up homeless, incarcerated, or in hospitals. Senate Bill 318, adopting the social worker licensure compact, would allow other social workers from other states to practice in the state, thus reducing the workforce shortage. And for that reason, NAMI New Hampshire supports this bill. Thank you for your time.
Thank you for your testimony. Questions? Senator Altshuler.
Thank you, Mr. Chair. Thank you for your testimony. Just for clarification, when we were experiencing COVID and all of the ways that we allowed for people to access mental health services using telehealth outside of the scope of any compacts, and then that shut down, I think, in March of 2021, might have been it. Will this compact allow for that telemedicine to be able to resume? For instance, I had constituents whose students, children, adult children, had gone off to college, but they were receiving telehealth mental health services here in New Hampshire and wanted to continue with the social worker or psychologist that they had been working with, and were going out of state, and insurance was not keen on that after our the COVID exceptions expired. Will this allow for people to continue that relationship with a licensed social worker from New Hampshire if they're out of state for a short period of time? Is that how you see this?
I believe it would. And
Yeah.
I say I believe it would. I think that I'm not the best person to answer that question, but with our telehealth rules that we have in law currently, I think Lindsay Courtney would be a better person to speak to whether those would apply to people out of state and having the licensure compact cover them. Right now, as it sits, the person who is receiving telehealth services has to be physically in the state of New Hampshire.
Right.
I don't know if that would have to be changed as well. That's not something I know at this point, but I think there are other people that could answer that question.
Thank you.
I think Director Courtney has noticed that question. You'll provide an answer for the committee. Thank you. Further questions? Thank you for your testimony.
Thank you very much.
Warren Perry.
Good morning, Mr. Chair, members of the committee. For the record, I'm Warren Perry, Deputy Adjutant General for New Hampshire's Department of Military Affairs and Veteran Services, which includes the New Hampshire National Guard, the Division of Veteran Services, the New Hampshire State Veteran Cemetery, and the Division of Community-Based Military Programs. The department supports the bill for all of the reasons that you've heard before, but I just would highlight that increasing the portability of licensure not only impacts positively military members or military families that may move to New Hampshire, but it also those that are here that need care. It provides more workforce and greater capacity to meet those needs, social work needs. So for those two reasons and all of the reasons that you heard before, the department wholeheartedly supports the bill, and pending your questions, that concludes my testimony.
Thank you. Questions from the committee? Seeing none? We have two additional folks that signed in favor, and if anyone else has testimony they'd like to provide on the bill, please provide it in email to the committee.
Mr. Chair, could I ask one more question of Dr. Courtney while she's still here?
One quick
If she's willing.
I still have two more bills.
Really quick. On page 9, line 16 and 17, it says only the home state shall have the power to take adverse action against a regulated social worker's multi-state license. So before, when we were talking about the red flags that can be raised in the application of a license, right? So let's say somebody is part of the compact, and there is, professional misconduct that is now being investigated in, name a state, Massachusetts, right?
Yep.
And this person, has subsequently moved here to New Hampshire, part of the compact, they're working, and it's being investigated by Massachusetts. Is that investigation at least shared with New Hampshire, so New Hampshire cannot take any action unless something happened here, even if there's an investigation of misconduct in another state in the compact?
So that language refers to the fact that there's one home state license, and that home state license is like punches your ticket to be able to work anywhere else.
Yep.
So that home state has jurisdiction over that entire process. If you were to revoke that home state license, all of your privileges to work in another state would go away immediately. Now, that said, every state in which the person works, they're working under authorization pursuant to the compact. That state retains jurisdiction to say you can't work here, and they would have to go through the traditional requirements of due process, notice and opportunity to be heard. But they could discipline you and say, even though we can't take away your entire license, we can take away your ability to practice in New Hampshire. And we see that a lot when there are certain states that take different positions on certain issues of misconduct. For example, abortion is one of them. With respect to physicians, some states take different positions on misconduct as it relates to providing abortion services. So some states will find that a certain action is misconduct, and another state will say the same action is not misconduct. Each jurisdiction has the ability to discipline under their own state laws.
But if somebody from New Hampshire, right, applies and enters into the compact here, right?
Correct.
Then they subsequently move to another state that's part of the compact.
Yep.
They are still, any disciplinary action if their misconduct was in another state of the compact has to come back here for us to deal with if it was happening in another state. That's the part I'm not following. With this home state has the power. So
think about the home state has the authority to take away that privilege for you to work anywhere, regardless of where the action occurred, right? Because you're utilizing that, you're using that license to work anywhere. But each state has the ability to discipline in accordance with their state laws for the conduct in their state. You could certainly do that.
So if a person violated the code of conduct in Massachusetts, but they originally retained their license in New Hampshire, as part of the sharing of information, New Hampshire would get that information that somebody who originated here had gone to a compact state, had been, was brought up on disciplinary issues for whatever. Now that flag goes into the system for all the compact states. And New Hampshire's response to that is to, what I don't see is, do we just, duly noted, we see that the other state, had some sort of, performance enhancing program or, or do we have to now pull that back and bring that person under a disciplinary action here because we're the state that got them in it in the first place?
Correct. So the compact doesn't speak to the state's procedures for investigations and discipline. It just requires that you have that process in place because the compact is not going to dictate that. And different states have different views on what constitutes misconduct. And so we would use our existing state laws and existing state procedures and discipline accordingly.
I think I've got it.
I'm happy to talk offline too, Senator Altshuler, anytime if you'd like.
Thank you for
Thank
coming
you.
back up. All right, with that, I'm going to close the hearing on Senate Bill 318. Good morning, and again, for the record, my name is Senator Howard Pearl from District 17. I reside in the town of Loudon. I am here today to introduce Senate Bill 486. Senate Bill 486 would have PAs join other healthcare providers who enjoy the benefits of a multi-state licensure compact, including physicians, nurses, psychologists, physical therapists, speech therapists, occupational therapists, counselors, and hopefully social workers. There are others set to testify after me who will provide more information on the PAs in New Hampshire and how exactly this compact works. I just want to make a few points. The bill continues efforts by the legislature, the governor, and OPLC to streamline licensure processes in New Hampshire without sacrificing safety. This is really a healthcare workforce bill. This will do for PAs what physicians and nurses enjoy, which is to allow the PAs to practice in more than one state, which is important given how close we are to our neighbors. I'd also like to note Maine and Vermont are among 12 states considering this PA compact legislation this year. It will make New Hampshire more attractive to PAs, which will mean more qualified healthcare providers here in the state. And perhaps most important, I want to make clear that joining the compact it does not change the scope of the PA practice in any participating state. Only the state legislature and Board of Medicine can change the scope of practice for PAs in New Hampshire, and this bill would not change that. More directly, joining the compact cannot provide a path to independent practice of medicine for PAs in New Hampshire. And a PA coming from a state allowing PAs to practice independently could not practice independently in New Hampshire. The PA would be required to follow all applicable laws and regulations governing a PA practicing medicine in our state. Again, you'll have other folks that are going to explain this a little more thoroughly than I can, but I'm happy to take any questions if you've got any.
Thank you very much for your testimony, Senator. Are there any questions from the committee? Seeing none, thank you.
Thank you. Director Courtney. Oh, I guess it's going to be Doug. That's okay.
Douglas Osterhout, General Counsel for the OPLC. I don't have much to say on this other than I understand Executive Director Courtney went over the two types of different compacts in her previous testimony, and that the OPLC is in support of this compact, and this would be the privilege model, I believe it's called. But beyond that, I don't have much to add here today.
All right, thank you. Any questions for Doug? Senator Altshuler.
Thank you. So hopefully you can answer my question here. So similar to the last bill we heard, I understand that this is a privilege to practice model. On page 13, lines 1 through 3, so it says the commission shall promptly notify all participating states of any adverse action taken against a licensee or an individual applying for a license that has been reported to it. This adverse action shall be available. So if we grant a license here in New Hampshire, again, same question, they go to one of the compact states, there is disciplinary action taken in that state. How is that addressed here in New Hampshire? It seems, unless I'm not understanding the process, that this becomes a regulatory burden on New Hampshire because we're now having to address adverse actions being taken in another state. So if there's disciplinary action taken in New Hampshire for whatever the problem was, disciplinary action taken in the compact state, and then it has to go into the system that we heard all about that shares that information. Now, if there is a question of that person being able to maintain their license within this compact, it now comes back here for us to reevaluate that person's license because they are part of our compact, right?
I believe so, yes.
Okay. Thank you. That's the clarification I'm looking for. It's like, where does the discipline, there's a disciplinary action, but if that person, let's say they were just a New Hampshire license holder, there was a disciplinary action taken, the board would have the option to reevaluate if that person should continue to be licensed in New Hampshire, correct?
They would, I don't know if it's directly related to licensure, they would have the option to proceed with discipline if they so choose.
Yes.
Which could be up to revocation, suspension.
Right, or revocation. So there's
Correct.
those three options for somebody who's practicing in the state of New Hampshire and there's a disciplinary action.
Yes.
It goes back to our board where they review and they're like, okay, we see that, you know, the hospital took this disciplinary action and think that that's appropriate and we're ready to move on and let this person continue to practice. Or the board actually reviews and says, you know what, this is the third time that we've had this, we're going to suspend until certain criteria. That's a lot of power that the board here holds over a person's license. And that's a lot of interaction, right? But if we enter this compact and now any of those things happen in another state, our board, if I understand this correctly, is going to do exactly the same thing they did for the person who was in New Hampshire, but now they're hearing this information as it comes from another state. Because the other state cannot suspend or revoke a license in the compact, correct? Only your home state has the authority. Am I understanding that correctly?
Correct, but from the administrative burden side of New Hampshire, we would treat it like a regular hearing. I think the burden would be on an individual out of state having to make it here for a hearing. But there is also the ability to testify via Zoom, that's in statute, or some electronic means. So I'm not sure the burden would be.
No, the mechanics aside is that the board here in New Hampshire has to address those, whether they do it via Zoom in a room, that's neither here nor there, but they're addressing disciplinary action taken against someone who received their license as part of the compact, but they originated here in New Hampshire and then now they've moved to another state.
If the New Hampshire wanted to take action against that licensee, it would require board action, correct?
Okay. Thank you. I get the mechanics now. Yeah, thank you.
They also, the licensee also has the ability at any point in time to let their license go from New Hampshire and pick it up in another state, correct? They could do that if they chose to, in the sense of they could relicense through the compact in a different state that they're now residing if they wanted
If it was a
control of that.
compact
Yes.
state, they could
Yes.
apply in that state.
That's what I thought. Thank you. Further questions?
Thank you, Mr. Chair.
So they could relinquish their license in New Hampshire.
Okay.
Say you moved to Oklahoma and they're a compact state. And
Yep.
you plan to stay there for
Ever.
whatever.
Yeah.
Then you could redo your license in Oklahoma and not be under New Hampshire jurisdiction.
Okay, and re-enter the compact
Through
through
Oklahoma.
now your current
Still be
home
subject
state.
to the same rules, but,
Thank you.
You're welcome.
Missed that bit. Thank you. Appreciate it.
all right, thank you, Doug. Sarah Leslie? From the New Hampshire Association, or Society of Physicians Assistants, I'm sorry. I had to read again. It's nice not to have to my eye on the clock. I'm sorry, I promised the Senator Altshuler I wouldn't go back to the bad eye puns, but I had to. Please continue.
Good morning, Mr. Chairman and members of the committee. My name is Sarah Leslie. I'm a licensed physician assistant here in New Hampshire, and I reside in Deerfield. If I may, before I get into my testimony, if I could provide a little bit more clarification about some of the questions that Senator
Sure, certainly.
Altshuler was asking, and also you as well. The last one, if the license, so if we were to enter the compact, New Hampshire license is my ticket into the compact. If I were to move and if I relinquished my New Hampshire license, I could no longer receive compact privilege unless I were to then get a license in a state. So say I went to Utah and I was then licensed, and that would then be my ticket back into the compact.
Right.
Also, when it comes to disciplinary, New Hampshire can't take away the compact privilege for another state, and nor could a compact privilege be taken away. So say Utah can't take away my license in New Hampshire or compact privilege here. We don't have to take action, or excuse me, the Board of Medicine wouldn't have to take action unless it was a discipline, an adverse event that was wrong here. It's similar to what Director Courtney was saying with abortion. So if one state it's not, if the state it is, they can take action against your license, but in the state that it's not, they don't have to do anything. But it's no different than, I hold multiple state licenses. So if being in the compact, it's no more burden on the board than what it would be already. So if I did something in Pennsylvania and I'd have to then report that action to the board if something happened to my license in New Hampshire, or excuse me, in Pennsylvania, they would have to get that same information. So the same process is already in place. This is only a streamlining the ability to obtain a license, excuse me, a compact privilege in multiple states. But the same process is already in place for those of us licensing process. But I will get back into my testimony. I apologize. Did that answer your question? Okay. So I'm the Vice President of the New Hampshire Society of PAs and co-chair of the Society's Legislative Committee. I'm here this morning on behalf of NISPA and the over 1,000 PAs in New Hampshire, the students of the Masters of PA programs at Franklin Pierce and Mass College of Pharmacy and Health Sciences. NISPA supports SB 486, which would have New Hampshire join the PA Licensure Compact, and we did submit a letter for the record. Thank you, Senator Pearl, for introducing this bill. Many people are not entirely familiar with what a PA is or think of PAs as assistants to physicians, which was true up until about 40 years ago. But the PA profession in New Hampshire, Anacostia becomes active. To date, 3 states have adopted it: Utah, Delaware, and Wisconsin. The legislation is pending in 11 other states other than New Hampshire, but those also include Maine, Vermont, Rhode Island, and New York. Licensure compacts are an important tool to help ease the licensure process for professionals moving from one state to another, especially in the healthcare field. Joining the PA Licensure Compact will help the healthcare workforce crunch in a small but meaningful way by making New Hampshire more attractive to PAs. Facilitating multi-state practice through license portability and allowing PAs mobility in public health emergencies will be beneficial to PAs, their employers, and their patients. This will impose one state scope of practice laws or regulations on another. So thank you for hearing my testimony. I'm happy to take any questions.
Thank you very much for your testimony. Are there any questions from the committee? Senator Altshuler.
Thank you. And on page 19.
Yes.
This was mentioned prior, section 13, the binding effect. And Director Courtney mentioned this. So part A, nothing herein prevents the enforcement of any other law of a participating state that is not inconsistent with this compact. Any laws in participating state in conflict with this compact are superseded to the extent of the conflict. So if there are procedures that are prohibited in a compact state, and you say a Utah doctor comes here and there are prohibited procedures, how does that work?
From my understanding, they would have, anytime I get a license or a compact privilege in another state, you have to then learn the laws and regulations of that state. So if they're coming from Utah, they then have to come and learn what they can and cannot do here. It is their responsibility, it is on them, and therefore also if they do something wrong, it's on them and their license if they do something inaccurately. So for the PA that's coming from Utah, they would just have to read the laws and regulations. It's my understanding. Does that answer your question?
May I follow up?
One quick one.
And the scope of practice between the compact states is equitable?
No.
It is not.
Scope of practice, so up until about 5 or 7 years ago, the PAs have been under supervision, working under supervision of a physician. Over the course of the last 7 years, different states, and including New Hampshire, we have moved the needle on scope of practice for PAs. So the scope PAs can all do relatively the same thing. We're all trained the same way. We're all going from accredited schools from the ARC PA, so our education is standard across the board. There are some states that are a little bit more conservative, and prescription practice might be different for what they can prescribe, and certainly whether it's narcotics or whatnot. But when it comes to seeing, evaluating, treating, that's all the same. But when I say scope of practice is different, I look at it from supervision versus collaboration versus independent practice. The only really big thing would be is that the prescriptive practice in some states, very few, I might add, some medications are not allowed to prescribe in certain states. But otherwise, it's only the supervision piece that's different.
Thank you. Further questions? All right, seeing none. So Warren Perry and Melissa Lillette, I kind of think you're both on the same page on this. You want to just kind of come up together and give a quick...
In the interest of time? Absolutely. Again, for the record, Warren Perry, Deputy Adjutant General, New Hampshire's Department of Military Affairs and Veteran Services.
Melissa Willette, New England Region Liaison for the Department of Defense, and we're here to support our military families and military spouses. This compact, like the other compacts the DoD supports, would facilitate that support for our military families, which is why we support the PA compact.
The department supports this bill also for the same two reasons we supported the social work compact. It not only increases portability of license for our military families and military members when they come to New Hampshire, it also creates capacity for treatment in our hospitals and medical care for not just veterans and military members in the state, but for everybody.
Excellent. Thank you both. Appreciate you coming in. We have one more who signed in favor, not wishing to speak. And anybody else who would like to submit testimony, I would ask you to do so to the committee through email. And with that, I'm going to close the hearing on Senate Bill 486.
We're going to open up our final bill of the morning. It is Senate Bill 488, and we recognize prime sponsor, Senator Pearl.
Thank you again, and it is still morning, so good morning, committee. For the final time today, I am here, I'm Senator Howard Pearl from District 17, residing in Loudon, and I am here to introduce Senate Bill 488. This bill is a housekeeping bill to clean up two separate and entirely unrelated regulatory items pertaining to PAs. The first part of the bill deals with continuing medical education record keeping. Specifically, it gives the OPLC and the Board of Medicine the ability to maintain CMEs for the PAs who choose not to maintain their accreditation. The second part of the bill corrects an omission in the state statute that was entirely inadvertent. Current law exempts around a dozen healthcare providers from needing a barbering, cosmetology, and aesthetics license. I don't hate estheticians, I just don't like the word. For no reason at all other than an oversight, the PAs were not given an exception, even though doctors, nurses, and many other practitioners were exempted. This bill simply exempts PAs from needing this license. Like the last bill, others will follow to get into greater detail and be in a better position to answer questions. I do know that we may need an amendment on this to correct a drafting error, but I figured we would go through the testimony and then we can either do one as a committee amendment or I'll have one drafted. So I think Ms. Leslie or Mr. Kuzi probably can explain what's needed better than I can. So with that, I'll take any questions.
Thank you very much for your testimony, Senator. Are there any questions? Okay, seeing none.
Thank you.
The chair will call Doug Osterhaus.
Good morning, Douglas Osterhout, OPLC. The office doesn't take a position on this bill, but I did just want to comment. You mentioned, Senator Pearl, there may be an amendment. Section M of 328D10(1) is actually the rulemaking for physician assistants. I think all we would have to do is modify the language slightly, because it says the Office of Professional Licensure and Certifications maintaining of continuing medical education. We would track any reporting requirements. The boards would actually set those requirements. I think that's a pretty simple change. I could play around with the language a little bit to make it fit a little better in the statute.
You'll get that language to me, your thoughts on it?
I can do that.
Okay, thank you.
And that was all I had to, I just wanted to bring that up.
Questions from the committee? Seeing none? Sarah Leslie. Please. That's all right. Dave Cuzzy will put you right on here.
All right. Well, good morning once again, Mr. Chairman and members of the committee. For the record, my name is Sarah Leslie. As mentioned previously, I'm a licensed physician assistant here in New Hampshire, and I reside in Deerfield. I'm the vice president of the New Hampshire Society of PAs and co-chair of the Society's legislative committee. As Senator Pearl noted, this bill would clean up two unrelated issues pertinent to PA regulations. The first item deals with continuing medical education record keeping. Specifically, SB 488 gives OPLC and the Board of Medicine the ability to maintain CMEs for those PAs who choose not to maintain their NCCPA certification. When SB 228 was passed 2 years ago, we became one of the many states that removed the legal requirement that we maintain our NCCPA certification. Most of us will maintain it. It's the same as the board certification for physicians. You sit for a high-stakes exam, keep your certification. But for PAs that are retired, they don't necessarily want to sit for a high-stakes exam, which is really the only people this pertains to, because most of us, hospitals and our employers require we maintain our certification for credentialing. Also, some malpractice insurance companies also require we maintain it. So it's less than 5% of PAs nationally that would not maintain it. But so morally, it just affects those PAs that are retired. They don't want to sit for a 3-hour exam, but they do want to maintain their license. However, when we drafted that in SB 228 and that was passed, we did not have a mechanism in place for the Board of Medicine to keep track of those CME, because right now our NCCPA certification tracks our 2-year cycle of continuing medical education credits. If you don't maintain your certification, they no longer track your CME. So OPLC was kind enough to offer to track it for those small amount of PAs, but unfortunately we didn't draft language in that bill 2 years ago to allow the Board of Medicine to do that. So PAs who maintain their certification, the CME is tracked by the NCCPA, as I previously mentioned, and state law does not require PAs maintain their certification, but it does require that we maintain our CMEs. So this fix simply gives OPLC the ability to maintain the CME for those PAs who do not maintain their certification. And the second part of the bill corrects an omission in state statute that was entirely inadvertent. Frankly, we continue to look as a legislative committee to find statutes that omit PAs. It was not intentionally done, but unfortunately when laws are passed for physicians and NPs, PAs keep getting forgotten about. So we spend our free time looking through all the statutes and regulations and finding where we're omitted. And that's the case for the second part of SB 488. Current law exempts many healthcare providers from needing a barbering, cosmetology, and aesthetics license, and just due to oversight, PAs were not given the exception, even though doctors, nurses, morticians, and so many others were. The bill simply exempts PAs from needing that license from that board. There was a drafting error that requires an amendment. Dave Cuzzy can explain the drafting error and the proposed fix. With the chair's permission, I'd like to hand it over to Dave, but I'm happy to take any questions from the committee to discuss the desired amendment. So thank you, Mr. Chairman.
Thank you, Mr. Chairman, members of the committee. For the record, my name is Dave Cuzzy with Prospect Hill Strategies here in town, representing today the Society of Physician Assistants. This is a simple fix. I hope I don't make it more complicated. In the bill, you'll notice part 2 of the bill starting on page 7 and then proceeding down to page 9. You'll notice that the bill looks to insert a subparagraph on line 3, and I did pass around the relevant statute for reference. If you'll notice in the statute, it's RSA 313A, and then 25, the exemptions. Each of the practitioners that are exempted get their own paragraph, their own Roman numeral. For whatever reason, when this bill was drafted, it put the PA exemption as a subparagraph under Roman numeral 3, the commissioned medical or surgical officers. The concern is that would limit the exemption to PAs who might fit in that category. I guess, to be very simple, we need our own line, not a subparagraph. So there's a few ways, I think, to go about this. We could insert after Roman 1 in the statute, we could insert the PA, the language that's in the bill on line 9. We could insert that right there as its own Roman numeral 2, and then renumber the Roman numerals after that. Or if it's easiest, unless there's a reason why you can't just list it last and save the renumbering, you could list it in the statute under, if my Roman numeral reading is correct, I guess that would be Roman numeral 13 and all the subparagraphs under
14.
that. 14, so I did get it wrong.
Yeah. You'd add.
I'd add 14, I'd
Yes.
insert it out, yes.
Yeah.
Yes. So that, I hope that, that's the amendment that we think needed that, of course, and what OPLC was suggesting for part 1 of the bill regarding the CME record keeping. And I'm happy to work with OPLC and just draft something and we can get that over quickly.
Doesn't seem too bad. Yeah, just get some language to me if you want to work with OPLC and come up with something that we can put in, and we can do that as a committee amendment, or I can draft one. We'll see what it looks like.
Great. Thank you, Mr. Chairman.
Thank you. Questions from the committee? Senator Carson.
Thank you, Mr. Chair. Thank you for your testimony this morning. I would suggest that instead of making it 14 down at the bottom, just for continuity and make it easier for the licensees that are under this particular exemption to try and keep them together. So it would be a 1A, because you would have the physicians and then the physician's assistants right underneath them. And it would make it easier statutory-wise for the licensees to follow.
May I, Mr.
Thank
Chair?
you. Please. Just a suggestion.
No, so I think Senator Carson, so we could say physicians and surgeons under Roman 1 in the statute, physicians and surgeons licensed under RSA 329, and physician assistants licensed under 328D when engaged in the practice of their profession.
Yeah, I just didn't
I had that thought
putting
too,
that
but-
all the way down at the bottom, because people are just going to look up at the top, and it's going to take them a little while to get down.
Yeah, and both are regulated by the Board of Medicine, so that makes sense.
Okay.
Thank you.
Thank you.
Further questions? Seeing none? Thank you for your testimony.
Thank you.
I have no further people to testify on the sheet, and there's nobody else in the audience, I don't think. Karen, unless you want to testify on this. All right, I didn't think so. With that, we'll close the hearing on Senate Bill 488. For the benefit of the committee, I'm not going to exec anything today because we're running really late, but I do want to say be prepared next week that we will exec some bills. So if there's thoughts you have on them, we'll plan to do that. And with that, we are going to adjourn for today. Thank you all.
Thank you.